I must say that they gave me a completely free hand, which is a rare thing these days. So I sort of chose the topics and chose the speakers. In trying to put the program, I sort of cherry-picked what I think is significant, either because of the burden of the disease process, like for example, with rheumatic fever, rheumatic heart disease and hypertension, or where there are major challenges in management, like in pediatric cardiology and pediatric cardiac surgery, or areas that are evolving, like interventional cardiology, and of course, to give us a broad overview globally and within the country. One of our guest speaker will talk about the global burden of cardiovascular diseases, and Dr. Mare, who from the Ministry of Health, will give us an idea as to what activities that we are having locally. So I hope that it will be a useful session, that it will generate many ideas. I deliberately made it not too clinical because I know we have a varied audience, but rather to look at cardiovascular diseases in a more holistic and societal level. So welcome to the show, as they say. I'm looking forward to very robust discussions. We've given quite a lot of time for discussion at the end. Maybe just one final thing is that we discussed and felt that 3 continuous hours is probably a little too much to sustain for the audience. So after the 3rd talk, which I think is the talk on rheumatic fever, rheumatic heart disease, we'll have a 10-minute physiological break and then resume, which means then our question and answer time will be a little short, but it will be still more than half an hour. So with those opening remarks, it is now my pleasure to welcome our guest speaker and first speaker, Professor Neil Poulter. Professor Neil Poulter's resume is very large, so if I went through all of it, we might occupy the entire 3 hours. He's a professor and chair of preventative medicine at the Imperial College London. He is a past president of the International Society of Hypertension. He's been involved in many of the landmark clinical trials that have shaped our management of hypertension. Currently, he's involved in a number of guidelines and consensus documents that guide cardiovascular epidemiology. From an African perspective, he's got very close links with Kenya. I first knew him when he didn't have the bald hair and I didn't have the gray hair, when he was a young researcher and I was an even younger resident at the University of Nairobi, which is where he really started his research career. Those of you who have heard about so-called Luo migration study, that is him. We continue to have very, very close cooperation. And as president of the Pan-African Society of Cardiology, I can tell you that he's been a very good resource person for us, especially in the field of hypertension. So with those very, very, very brief summarized introduction of I forgot to say that probably the most important thing is that he's my friend. So with those very brief remarks, let me introduce Professor Neil Poulter to take us through the global burden of cardiovascular diseases and especially how it relates to the African situation. Neil, welcome.
Thank you very much indeed, Elijah. I'd just like to start by thanking the Dean and Professor Agola very kindly for inviting me to join this really exciting symposium on the Thursday. This is your 4th day, I understand. So in the next 30 minutes or so, I'm going to address this burden of cardiovascular disease at the global and African, from a global and African perspective. I'd like to think I don't have a conflict of interest in relation to blood pressure, glucose, or lipid-lowering agents, but I put this up for political correctness anyway. So the top line or bottom line is that cardiovascular disease is the biggest single killer in the world currently. And this quote from Salim Yusuf, because cardiovascular disease affects a third of adults in the world, it's the largest epidemic, it's a pandemic ever known to mankind. And there's some of the figures around that. 523 million people have had cardiovascular disease in 2019 around the world. A third of all global deaths are from cardiovascular disease, and 85% of cardiovascular deaths are either heart attacks or strokes. Now, this is the situation of the cause of death in Africa, slightly different. You see, the world is that leading cause of death is neonatal conditions, and that comes down here. But you see, if you put stroke and ischemic heart disease together as cardiovascular disease, they're just in second place behind neonatal conditions. Now, just referring to how things are going around the world, this shows the top cause of death. And as I said, cardiovascular disease is by far and away globally the biggest single killer. Combine these two, and the blue line is 2015, the red line 2000. So things are increasing for both ischemic heart disease and stroke. But globally, these are the top two, which together make it by far and away the biggest single killer. And as you saw on the previous slide, not quite the same as we see in Africa. And it varies around the world, this ratio of ischemic heart disease to stroke. Sub-Saharan Africa, slightly more ischemic heart disease than stroke. These are percentages of cardiovascular deaths. In Western Europe, ischemic heart disease is twice the stroke rate. America, it's about 3 times the stroke rate, ischemic heart disease. But globally, there's a good increment of ischemic heart disease over stroke, incorporating a few parts in the Far East where stroke is more common than ischemic heart disease. So, do we know what the real causes of cardiovascular disease are? Well, there was an article published about 30 years ago which listed 283 different risk factors which have been so-called well, not causative, but associated with coronary heart disease. And I chose a few of those, which I don't particularly believe. Actually, in all fairness, if we take snoring into obstructive sleep apnea, that is a real causative risk factor. But these others aren't causative, at least I hope not. Not having a siesta, non-English tongue, beard growth, novus. These are just associates that are found to be statistically significant. They're not real causes. Now here's one thing, a sort of negative way I'd like to start and say, this shows over a 10-year period, it doesn't matter what the period is, but it's 1998 to 2008, the percentage change in coronary death rates in each of these countries down the left-hand side, European countries. And you see some of these European countries here with over a 50% change, reduction in coronary heart disease death rates in a 10-year period. So what does that tell us? What's the key finding in that? There's a big range around Europe, a few countries down here getting worse. And sadly, there's Ukraine. You can imagine how that's going to go a lot further in that direction at the moment. But the point about this slide is that you've got these huge changes in a 10-year period. And that tells you something. And it is that this condition, coronary artery disease, is not primarily a genetic disorder. It is primarily about the environment, which interacts at the individual level with genetics, but primarily this is an environmental problem, not genetics. I want to keep this very simple. If we go back to the multiple risk factor interventional trial, MERFIT, they screened over 1,300,000 men. And this slide shows the results in a follow-up of those screenees. And what they did is they got the 1,300,000 screenees and they took out those who got diabetes and those who'd already had a myocardial infarction and subdivided the remainder into low risk and the rest. And low risk was just being a non-smoker, having a cholesterol less than 4.7. For those who are into milligrams, it's about 160, it's about 170 milligrams percent. and a blood pressure less than 120/80. So being a non-smoker, low cholesterol, low blood pressure, and not having diabetes, the coronary death rate was 2 per 1,000. Now that coronary death rate is less than you see in, for example, Japan. It essentially gets rid of this epidemic of coronary disease. The rest who didn't have or had some of those risk factors, that was 7 or 8 times higher than you saw in the low risk people. So on the basis of essentially 4 risk factors, smoking, cholesterol, blood pressure, and diabetes, you get rid of this as a pandemic, as an epidemic. It's a relatively rare disease on the basis of 4 risk factors. Coming up to speed slightly more recently was the InterHeart study. This is a big case control study, and it showed 9 risk factors which accounted for about 90% of the population attributable risk, i.e. the action. 90% of the damage of coronary disease in men and 94% of women was attributed to these 9 risk factors. And that was true in men, women, young, old, and in the 4 continents. And these 9 risk factors are down here. Smoking, ApoB or ApoA, that's equivalent to LDL and over HDL, but it's more expensive and it's actually a better predictor of cardiovascular events. Hypertension, diabetes, central obesity, and psychosocial factors. They are the 6 baddies, but 3 were found to be protective. Fresh fruit and vegetable, alcohol, it's not popular, it's not politically correct to say so, but there's a massive evidence suggesting that alcohol in moderation is protective for coronary disease, not so stroke, but for coronary disease, and physical activity. So 3 goodies, 6 baddies explains the vast majority of the action in terms of causing coronary artery disease. And I just want to highlight this. If you think about coronary heart disease in the middle, and I've said in the middle, put genes in there, as I mentioned earlier, this is not the primary driver. We are to an extent protected by our genes, but if you have very low LDL cholesterol, then you will not get a myocardial infarction. You've got all the baddies around the outside, or some of them: dyslipidemia, smoking, high blood pressure, glucose intolerance as the tip of the iceberg of type 2 diabetes, and central obesity. These baddies around here are fighting against this trench here, against the protective things. Alcohol, I've mentioned, exercise, dietary monounsaturates, fruits and vegetables, high HDL cholesterol, fish, and in secondary prevention, certainly aspirin. So goodies against the baddies, finish up driving towards coronary disease. But if you've got very low LDL cholesterol, you will not get coronary artery disease. Atherosclerosis is totally dependent on LDL cholesterol for its generation. Without atherosclerosis, you won't get coronary artery disease as we know it. So that's a pivotal bit of understanding. Now, that is not the case with stroke, where the pivotal risk factor is blood pressure. And this is a different way of getting to that. About 40% of strokes attributed to a systolic blood pressure of 140 and above. And if you go down to where blood pressures really should be, so 115 systolic, 2/3 of strokes are attributable to blood pressures above that level. Stroke is driven, the pivotal risk factor is raised blood pressure. So now let's turn to deaths around the world. Women at the top, men down below, and the different colors represent different sorts of death, causes of death. And this pale blue color up here is cardiovascular disease. This is cardiovascular disease, this is, and this is, etc. And the causes are ranked at the top on the left. And I've got here, I put arrows by it: systolic blood pressure, plasma glucose, and high body mass index. Put them together, that's diabetes. High LDL cholesterol, the pivotal risk factor. So 4 of the top 7 with these 3 risk factors: systolic blood pressure, so raised blood pressure, diabetes, and LDL cholesterol. Similar story, slightly different order amongst men. Men, the biggest single killer is tobacco, but that's the cardiovascular bit. Of course, smoking kills you lots of different ways. But we come back to the 4 that I mentioned before, or the 3 main diseases: systolic blood pressure, diabetes, and LDL. Notice it's difficult to tell because of the different color scheme here, but the rates of cardiovascular disease among women are much less amongst men. There are 2 coronaries amongst men for every 1 in women. That's pretty much all over the world. Double the rate of coronaries in men than in women. The increment for stroke is not that big. It's about a 40–60% increment amongst men than women for stroke. So if we think about those 3 risk factors, hypertension, dyslipidemia, and diabetes, we see here that these overlap. These 3 key risk factors overlap. For example, those with hypertension, 2/3 have got dyslipidemia, 1 in 6 are diabetic, and nearly half are overweight or obese. And this is, you see, the sad shape that we're all getting into. Dyslipidemia, similar sort of story, and diabetes, perhaps the worst example. Those with diabetes, almost 2/3 are hypertensive, 2/3 are dyslipidemic, and 90% are overweight or obese. So these 3 risk factors, not only are they 3 huge killers in terms of cardiovascular disease and death globally, they overlap more than chance would predict. So let's have a look at these risk factors by region. Sub-Saharan Africa, and the second column, Western Europe, North America, and globally. Starting with smoking, taking those over 15 years, the smoking rates, although they're increasing and they're bad in Sub-Saharan Africa, it's not as bad as it is in the rest of the world. Western Europe, 3 times as much. North America, about double the rate. And globally, incremental compared with what you see in Sub-Saharan Africa. So a relatively small problem, but increasing. Hypertension, on the other hand, is somewhere in the 30s in Sub-Saharan Africa versus being in the 20s in Europe, North America, and globally about 22. So one of the worst places in the world for raised blood pressure. Type 2 diabetes, well, here you see a bit of bias here because of age standardization, but in Sub-Saharan Africa, lower than you see in Western Europe and North America and globally. Dyslipidemia, lower in Sub-Saharan Africa than you see in Western Europe, North America, and globally. And then if we turn to obesity, well, you see the range here is less than you see for men. Let's talk about men initially. The range is lower than you see in Western Europe and North America. But if you go to the women in Sub-Saharan Africa, whilst the low end, there's a wide range and you've got lower rates in some countries, you've also got some high rates of obesity amongst women, and that bodes ill for the future. On average, it's probably worse than you're seeing in Western Europe, and maybe about a similar sort of situation you get in North America. So differences in terms of the risk factors in Sub-Saharan Africa and the rest of the world. Now let's just turn on to one. I showed these data earlier, but look, we have expected 1 billion people with obesity predicted by 2023, and you saw those high rates in Sub-Saharan African women. This bodes ill for the future, as I mentioned. Why, Bill? Because with excess weight, you get an increase in all the classical risk factors. Whoops, I'm sorry. Let's just go back. You get the blood pressure goes up, glucose goes up, insulin goes up, HDL cholesterol, the protective fraction goes down, triglycerides go up, which means the LDL cholesterol you've got is more atherogenic, you exercise less, more obstructive sleep apnea, inflammatory markers get going, and your pulse rate goes up. So it's not surprising that when you increase weight, with these big increases in weight, you get more diabetes and a whole increase in cardiovascular outcomes, because all of the standard risk factors get worse. The other thing that's worth considering and understanding about obesity is, apart from the diseases bottom left here, diabetes, cardiovascular disease, apnea, also cancer is increased. There's also dysfunction, pain, disability, discrimination, functional impairment you get from obesity, and also psychological well-being, eating disorders, depression, anxiety, and all these feed into each other. So this is a massive range of illness associated and around obesity that we have to take into account when we're trying to prevent it. So we know all these big problems. Have we got evidence that we can, if we intervene on them, there are benefits? Well, yes, there are. We've got good evidence of the development of hypertension. We can prevent that. The development of type 2 diabetes, we can do that. The treatment of hypertension, we can do that. The treatment of dyslipidemia, we can do that. And the treatment of diabetes. All these with drugs and or diets are established, they can be done. And in the background coming through is probably obesity too. The GLP-1A, some of them look fantastically exciting from that point of view. So the benefits of intervention are established for these main risk factors. Let's go back to a couple I didn't mention first time round. Here you see air pollution and tobacco amongst women here, high in the pecking order. And here for men at the bottom, tobacco leading killer and air pollution. So tobacco and pollution won't say much about tobacco. We don't need to say anything about tobacco. Everybody knows what a dreadful thing it is. And there's an increasing problem around the world, particularly in low middle income countries. And the low middle income countries are targeted with different level nicotine and tar, etc., in the cigarettes they produce by the evil of the tobacco industry. But let's just move on to pollution. Every year, air pollution causes about 7 million deaths. Both household and outdoor air pollution, will come back to that. But you see, these 7 million deaths from air pollution, a third from ischemic heart disease, and about a fifth from stroke. So very big numbers affected. But there's lots of sorts of pollution. Pollution is defined by unwanted waste of human origin. You can get is air pollution. So there's household, so in the house and outside. And it's the fine particulate matter which is often measured. I'll come back and explain that. Ozone and the oxides of sulfur and nitrogen constitute air pollution. But you get water pollution, the fresh water in the ocean, with mercury, nitrogen, phosphorus, plastics, and petroleum waste. And on the land, there's lead poisoning, mercury, pesticides, industrial chemicals, electronic waste, and radioactive waste. So all sorts of pollution contribute, but of the 9 million that all pollution causes, air pollution is the biggest contributor with 7 million deaths each year. How does that all work? Well, we inhale these fine particles. Now, that is a hair. You may say, what do I know about hair? But that's the size of a hair. So you get the feel of these tiny PM 2.5 particles. There they are. That's a grain of sand on the side. So you get a feel of how tiny these particles are. And we inhale them. And they go directly into the vasculature, giving cell damage. They cause stiffness of the arterioles and arteries, giving hypertension and arteriosclerosis. You get direct damage onto the heart with arrhythmias and heart failure. And then less clear is this switching on of the pro-inflammatory markers in the way that lean goes to obese adipose tissue. That switches on these inflammatory markers. So does these PM2 particles. It seems you get inflammation induced, and that gives you insulin resistance, diabetes, obesity, and other problems. So that's a crude look at how these PM2 particles, how pollution works on the cardiovascular system. But this is quite interesting. If we look men on the left, women on the right, what I want you to notice is the total air pollution in the purple at the top there is on the way up. Flattening out a bit in women and right up at the top of the pole for women, but for men here, not quite as bad as smoking, but pretty high. But notice at the other end, the red. This is household air pollution. So this is burning fossil fuels, etc. That has fallen over the last couple of decades through efforts around the world. So that's good. And that explains amongst women why some of the total air pollution has evened off. In men, it's gone up. And really what has continued to rise is the outdoor air pollution. A lot of it about big problem for all of us. Some good news for Africa is that if we look at traditional pollution between the year 2000 and the following 20 years, household traditional pollution means household air, burning fossil fuel, unsafe water, and hand washing, the sanitation side of things. These are all levels of improvement in green, which is great to see. Only here, I think that's Zimbabwe, isn't it? Your geography was better than mine. I think that's Zimbabwe. There's a slight increase there, but everywhere else in Africa has shown incremental improvements in this traditional pollution. That's the good news. But as you saw, the outside pollution is increasing, and that's increasing everywhere, particularly in LMICs. So to summarize the story of pollution, about 90% of the pollution deaths are for low and middle income countries. And most of the data that we've got about this are cross-sectional. They're not good enough. We need an increased generation of evidence-based interventions and studies of pollution to evaluate the health benefits and then demonstrate that we impose them and get them as part of policy. Now, pollution, climate change, and biodiversity are all closely linked. And controlling pollution is bound to bring, well, it's likely to bring broader benefits than just reducing cardiovascular outcomes. And one obvious thing is a move to wind and solar energy will reduce ambient air pollution, which kills 7 million people a year. So it's really worth some increased focus around the world. So what are our prospects for the future? Well, if we look at development around the world, what happens to risk factors? Well, with development, people get older, exercise get less, booze goes up, salt intake goes up, potassium intake, fresh fruit and vegetables, goes down, body weight goes up, stress, well, I think it depends how you define it, but I think that probably, it may be just different, whether it rises or not, I don't know, just different stresses. Smoking tends to go up, saturated fats go up. So you don't have to be an erudite audience like the one today to appreciate if that's what's going to happen around the world, in most of the world, then we've got a serious pandemic of increasing cardiovascular disease coming our way, because these are key risk factors, particularly for hypertension, but adding other risk factors for cardiovascular disease that you'll recognize, like the saturated fats and smoking, etc. So it seems that optimal cardiovascular disease prevention is a prevention of at least some of the aspects of development. Hitherto, development, all those things we just showed, development always gone with those things. It isn't too late to prevent that from happening, because we know what we need to stop, and that takes action. This is a horrifying reality that there are now more young people who are overweight through calorie excess than there are young people who are starving. This obviously, this ratio will differ around the world, and the African setting will be different, but globally, that is the sad situation. When we all go to medical school, we learn about marasmus and kwashiorkor. We do not learn about childhood obesity, and it's about time we did. And you finish with a situation like that when we know obesity is going to happen, diabetes on the way. So here you see these two babies. What are you going to be when you grow up? And the answer is diabetic. That's absolutely right. It's like night following day. Obesity drives diabetes, and we have to stop this pandemic of obesity. So what are the critical requirements for preventing and reducing cardiovascular disease? Well, the first thing, obviously, the long-term effort is through prevention. But that is a long-term goal. It takes on all sorts of other things. Short-term, we've got medications. These are being demonstrated for glucose, for diabetes, for lipid lowering. They've got to be made available around the world cost effectively. They are not at the moment. Nobody is using the injectable lipid lowering agents. Similarly, the SGLT2s and the GLP-1As in type 2 diabetes, hardly anybody's using them because they're too expensive. That has got to change. We've got to get the medications now that are available to the people in the world who need it now. Prevention, as I said, is a much longer term goal. Now, to get all this together, we've got to have education of everybody, primarily of the general population. They need to understand. Community health workers, all the way through to the hospital doctors, the whole range of the world needs to get educated about what kills us most. And at the moment, as I said, that's cardiovascular disease. But to get any sort of action with the medication, the prevention, you've got to bring together all sorts of forces. You've got to bring the pharmaceutical industry. You've got to bring educators. You've got to get the food industry. You've got to get the politicians all together sitting around, and the medical profession, all sitting around the table to work together to collaborate. And I think short term, we need legislation. It's a remarkable thing that in UK, and I think in Nairobi too, there are laws that says you've got to have a seatbelt. Now, hardly anybody dies of car accidents. In fact, I know we all know people who have done. But in terms of numbers compared to cardiovascular disease, compared to smoking-related deaths, it's absolutely minuscule. Yet there are laws about you must have a seatbelt in the back seat. No laws about smoking. We're allowed to smoke. That's got to change. There's got to be laws that stop people smoking in public places. And if they stand around the doorways of a restaurant, they have to be driven back 100 yards at least. It's got to be made incredibly difficult to smoke. We've got to make these laws. And I think for the other things, the fizzy drinks, all the things that we know, you've got to tax the bad things. McDonald's, Coca-Cola, all these things have got to be taxed out of sight. I'm afraid that sounds a bit draconian, but I think it's the right thing to do. We know taxation works against smoking. We've got to introduce it against the sugars and the sugary drinks and salty, etc. In summary, cardiovascular disease is currently the biggest single killer around the world and almost the biggest single in Africa. The adverse effects of cardiovascular disease will increase over the next decades because most of this is going to happen in low middle income countries where exposure to the standard risk factors is rising and will continue to do so. We know what the main risk factors are for cardiovascular disease, and the impending and worsening epidemic is largely preventable because we've got effective interventions for blood pressure, for type 2 diabetes, and brackets probably obesity and dyslipidemia. We have them. On the other hand, smoking and pollution remain significant challenges to us all. So with that, I'd just like to say thank you very much indeed for your attention.
Thank you so much, Neil. That is great as usual. Just a few announcements to those who may have come late. We'll have all the question and answer session at the end of all the presentations. That's one. Two, we are quite many. We are nearing 900. So I don't think raising hands will help. We have a Q&A icon at the bottom. Please put all your questions on the Q&A, not on the chat. Three is there's a lot of disturbance because of all these guys putting in the chat box, their emails for the CPD points to be mailed and all that. If you registered, it has been registered with the Secretariat, please. Don't interrupt the presentation. So after the global picture from Professor Polter, we come home, and I welcome a friend and colleague, Dr. Ephantus Mare, who is the head of the Department of Non-Communicable Diseases in the Ministry of Health. Some of these public health issues that we are talking about cannot happen without the cooperation of the civic authorities. And I'm happy to comment that the Non-Communicable Diseases Division has been a valuable partner. I interact with them quite frequently through the Kenya Cardiac Society, through the university, through the NCD Alliance. As Dr. Mare knows, sometimes spend so much time with them, I wonder whether the ministry should pay part of my salary. So Dr. Mare Ephantus is going to now take us through some of the activities in the control of cardiovascular diseases specifically, and non-communicable diseases more broadly in Kenya. Welcome, Ephantus. Is Dr. Mare and hello?
Can't find him among the participants.
Okay. Maybe what we can do then, who was next? It's Amy Okello, isn't it? So maybe we can go on to Dr. Okello's presentation as I try to look for him. So it means I have to do a fresh introduction. Amy Okello is a cardiologist. Sorry, Dr. Mare is just calling me. Let me answer him. Yes, Fantas. Oh, okay, fine. Let me do that. Secretariat, he says he's in the meeting, but he's not been made a panelist. That's why he can't, communicate with us. Could you please do that quickly? So Amy, sorry, I'll put you back on the hold. So please enable Dr. Mare to be a panelist.
He can raise his hand.
Hello, the same. Can you raise your hand? Oh, yeah, I can see it is coming on. Your presentation is coming on. Okay, that's fine then. Okay.
Good afternoon, everyone. This is Dr. Mare. I'm sure now I'm audible. Can you hear me?
Yes, we can.
Yes,
Oh,
yes, we can, yeah.
Thank you very much, and sorry for that hitch. As Prof has introduced me, I'm Dr. Fantas Mare from Ministry of Health, Department of Non-Communicable Diseases. And I am going to take you through what we are doing at the ministry in order to tackle the rising burden of cardiovascular diseases in our country. I have 15 minutes to do so, so I'll try to be very, very brief. And maybe those who have issues can note them down in the Q&A. Okay, so having said that, I'll start by basically doing the introduction, but I'll not say very, very much as far as the introduction is concerned, because Professor has taken us through this and it has come out very, very, very clearly. And therefore, for the interest of time, I beg to skip this slide, which just talks about the epidemiology and the burden of disease or CVDs in our country and globally. The professor, I'm sure he also alluded to risk factors. And as you can see, they are indicated there: tobacco, alcohol, physical inactivity, obesity, and all that. So I'll also not talk much about that because the professor has also talked about that very, very clearly. And then when it comes to the availability of cardiovascular services in Kenya, as per our Kenya Health Facility Assessment in 2018, it was realized that CVD services were available in around 62% of all the facilities. But of importance to note, most of these services were available in the private sector. Unlike where the norm would have been, most of these services would have been available at the public health facilities. Needless to say so, I want to say that one of the key leading, the guiding policy as far as management of non-communicable in general, and that is where we have cardiovascular diseases is concerned, is Kenya Health Policy 2014 to 2020. And in that policy, one of the things, it is very clearly indicated that one of the things we would want to do is halt and reverse the rising burden of NCDs in this country. That is one of the key strategic objectives in our policy. And the policy has 6 strategic objectives. And you realize that out of the 6, 5 of the strategic objectives are addressing non-communicable diseases, and whereby in these non-communicable diseases, that is where our CVDs falls in. I would want to maybe indicate as a ministry where we are really putting our effort when it comes to handling the burdens of NCDs in our country. Number 1, we are targeting strengthening health systems for response of management of CVDs. We want to make sure that our health system is able to very well handle the CVDs. And then number 2, we would want to enhance more sector collaboration. As you are aware, if you look at the causative factors of NCDs, you'll find that most of them are factors which are basically outside health sector, and therefore the need of multi-sectoral collaborations. We also need to really strengthen our primary health care. This is more so because of early detection and also appropriate screening for CVDs, and therefore this leading to early management and proper referral system. We would also want to, or we are also doing a lot when it comes to strengthening our advocacy, communication, and social mobilization, because as Prof was maybe presenting, it was very clear that in medical schools, or for those of us who have gone through medical schools, he has given a very good example, like what we learn of kwashiorkor malnutrition, but we do not learn of obesity. And therefore, that means the right time for us to communicate the right information is now and not tomorrow. Another thing we are doing at the ministry, and we continue doing, is that we really want to continue doing monitoring and evaluation, surveillance and research, as this will give us data which will enable us to make appropriate policy and also come up with very good strategic direction decisions. As for health system for management of CVDs, one of the key issues we would want to do is that we would want to strengthen CVD management at the primary healthcare level. That is in line with primary healthcare strategic framework. And with this, one of the things we would want to make sure is that we would want to start creating awareness at the very low level, level 1, that is at the community level. We would also want to make sure that whoever is creating awareness at that level has the correct knowledge and has the correct means to pass to the general population. And that's therefore being the case, we would want to build capacity, and we continue to build the capacity for our community health assistants. They are also called community health extension workers. These are called CHEWs in other words. We would also want to build the capacity of our community health volunteers. This has been happening along all our counties, and we have been able to really to build the number of our community health volunteers in Kenya to close to about 90,000. And all these community health volunteers, we are equipping them with the necessary knowledge. We also want to give them necessary equipment so that they can be able to do screening and also pass the necessary message as far as CVDs are concerned. Of course, in order for us to do this very ably, we have been able to develop training modules and job aids for community health volunteers, module 13, and we will continue to engage our foot soldiers with this document, and we are getting some good results out of this. Of course, this is happening at the county level, and it is happening with a lot of technical support from the national level, that is from the Ministry of Health, and other partners like KCS, that is Kenya Cardiac Society. Likewise, as you are aware, we are now living in the era of universal health coverage, this being one of the 4 main agendas of the outgoing government. It is my hope that universal health coverage will also be a key agenda of the incoming government, and from maybe the indication of the new leadership. We will have to continue embracing universal health coverage. Therefore, this being the case, we have been able to, and we continue to work very closely with stakeholders, including Kenya Cardiac Society, to make sure that we define, develop, and disseminate essential health packages for UHC, for more so for use when it comes to the National Health Insurance Scheme. And this has gone far into making sure that a number of packages have been developed to cater for cardiovascular conditions in this country. We would not even want to stop at that. We would even want to go as far as having packages for screening, and hence embracing preventive and promotive health for cardiovascular conditions in our country. Likewise, I know in this country, maybe as some of us might be knowing, we have a very strong cardiovascular technical working group working under the umbrella of NCD, Intersectoral Coordinating Committee. We would really want to improve all, and we continue to do so. We will continue to make sure that the decisions and the advice coming from the Cardiovascular Technical Working Group of the NCD-ICC, those decisions are taken into account and are embraced as far as the UHC coverage packages is concerned, and also for decision-making when it comes to implementation of the primary healthcare in this country. Likewise, we know in this country, we have a major issue as far as human resources is concerned. And in order for us to provide that very, very sound services, high quality services as far as CVD is concerned, as a ministry, we continue to map human resource needs for CVDs across the country at both levels, both at national and county levels. We also continue to work with the learning institutions to make sure that they come up with appropriate courses for our health workers, healthcare providers in this country, so that they can produce better healthcare workforce for managing CVDs. We have tried to strengthen the capacity of our health workers, and this has been through what we call in-service training, particularly for hypertension. And through this, we have been able to try to train 3,000 healthcare workers on hypertension. We continue to do this in collaboration with Kenya Cardiac Society and other stakeholders. Likewise, we have been able to review the pre-service training for clinical officers and nurses who are in our tertiary institutions of training. And likewise, we can not only review the service training for clinical officers of nurses and clinical officers without involving the lecturers. And therefore, we have also been involved, or we have also been making concerted efforts to make sure that our lecturers at KMTC are well trained on cardiovascular conditions. Also, when it comes to enhancing quality of care of CVD management across all levels, number one, we have tried to make sure that the services we offer in this country, as far as management of CVDs are concerned, are standardized across board, and also standardized from the lowest to the highest level. That by that I mean from level 1 at the community level up to the highest level, that is level 6. And in order for us to achieve this, we have been able to develop, review, and disseminate national guidelines and job aids for reference of when managing, when it comes to the management of CVDs. We have also tried to do a lot of integration to leverage on those programs which are doing very well. And one of the programs we are trying to leverage on in order to make sure that we come up with a very appropriate quality services for management of and screening for CVDs is through HIV/AIDS program. We are piloting this one in Migori and Kisumu with very, very positive outcomes. And it is our hope that once we are done with that pilot, we should be able to scale out this countrywide. We are trying very basic things like any patient who comes for HIV services. One of the key things they go through is taking basic things like vital signs, BP. But when we take this BP, we rarely act on it. And therefore, we would want to take this as a norm that when any patient go to any clinic, any BP taken should be taken serious and be given the appropriate attention it deserves. We are also trying to strengthen our referral pathway, particularly for CVDs, client. We know most of our CVD patients get lost in between the referral system because we have not established a very robust referral pathway. And this results to our CVD patients getting into, for them to get into the appropriate hand. It takes too long, and hence, by the time they are getting wherever they need to get to, it is more often than not too late. We are piloting this in Isiolo and Vihiga through PEN Plus project, among other places. We are also trying to make sure we really do strengthen the infrastructure for CVD management to all levels, from primary level, that is from level 1 to level 6. We would want to make sure that we have the basic equipment for management of and screening of CVDs. For example, like for the community health, at the community health level, we would love to have BP machines, we would love to have weighing machines and tape measures for determining whether one is obese or not, and therefore, and at the higher levels and the mid levels, we also want to put appropriate diagnostic equipment like echo. Needless to say, one of the things we have realized is that we have some, we really do not have a very elaborate way of making sure that we have adequate medicines for management of CVDs. And through this, we have continuously involved various stakeholders, including Kenya Cardiac Society, to make sure that we continually review our essential health product and technology list of medicines. And this being the case, we have been able to adequately advise our medical supply store to store adequate and essential medicines for management of CVDs. And in this spirit, we have also been able to develop NCD tracer medicines tool. And within this tool, we have a number of about 4 or 5 CVDs medicines in this tracer list. And therefore, we are able at any one given time to just give an approximate or to gauge the level of the medicines which are available for use by our patient. Likewise, we have also continued to engage various stakeholders, including various farmers and procurement entities, to make sure that we have CVDs, health products and technologies available to our facilities at a very affordable prices. I'm sure you've even heard like the leadership of this country calling for promoting for manufacturing of some of these products within our country, and this will go far into lowering the prices of some of these commodities, and hence the end effect is making sure that we have available medicine and technologies for management of CVDs patient in this country. We continue as a ministry to guide the counties and also at the national level to do what we call national quantifications for our basic needs of non-communicable diseases and of importance, the CVDs medicines, particularly for hypertension and diabetes. These are very important exercise because unlike before, where we could not tell how much medications we need for our patient in this country. Today, we can tell, for example, for hypertension, we need these quantities of drug, and therefore that really goes far into advising the leadership on the funds or on the resources to put aside in order to make sure that those medicines are available. Likewise, without adequate social mobilization and also creating awareness to the community, we might not go very far. Most of the risk factors associated with CVDs can really be mitigated when it comes to passing the correct information to the right people at the right time. And therefore, we have prioritized awareness, advocacy and awareness creation. And this being the case, we have also now started agitating for higher allocations of NCDs, CVDs interventions within our country. As we talk for today, the gap as far as NCD is concerned, the requirements for NCDs, the gap is so huge such that we really need to do a lot to make sure that the gap is adequately closed. There is also desire to develop and disseminate CVD prevention and prevention and control communication and social mobilization framework. We also need to integrate NCD advocacy, communication and social mobilization framework with other existing framework. Like we need to embed our communication framework within HIV, TB, malaria, so that we are able to leverage on those programs to make sure that our messages reaches as many people in the public as possible. There is also a concerted effort to advocate for enactment and enforcement of NCD factors regulation. For example, we are doing a lot to make sure that the regulations of controlling maybe cigarette smoking are followed to the letter. We're also doing a lot to make sure that there is increased taxation as far as cigarettes and alcohol is concerned. Also working on regulation on sugar-based beverages, and therefore this will go back to alleviating the CVDs in this country. We also make sure that we commemorate World Heart NCD days, and some of those days we commemorate World Heart Day, among many others. We are also doing a lot of mass media, and most of us, as we might have realized, we have been appearing in TV very, very frequently, making sure that our population is well informed. Of course, we have also put plans into places to make sure that NCDs and CVDs are fully integrated in UHC, so that when the decisions are made as far as making sure that we have universal health coverage, we in the world of CVDs, we are well covered. Of course, we plan to disseminate NCD strategic plan 2021 to 2025 across all the 47 countries. This one we have already done. And this one will go far into informing the counties so that when they are making their county integrated development plan, they will make sure that they factor NCDs and of importance, the cardiovascular diseases in this country. One of the key issues which has been a stumbling block when it comes to decision-making, policy-making, is data for NCDs and CVDs in this country. And therefore, we have established NCD research priorities, and we plan to conduct quite a number of research and to make sure that the decision we make are evidence-based. And for example, we have done a few CVDs research, which I may not have, because of time, I may not necessarily mention them. The other thing we are doing as a ministry, we want to make sure that we have established a very solid database for NCDs and CVDs in this country. We have already integrated NCD EMR, ENCD module in our Kenya EMR, so that we should be able to collect all data that pertains to CVD. We want to make sure that we know how many hypertensives we are living with, what medications they are on, are they on control or not? And we are at a very advanced stage as far as this one is concerned. We also are planning to establish various registries across the countries and also set centers of excellence so that we have a very good record of our CVD cases, and therefore this shall help us when it comes to planning and providing appropriate services. Likewise, I think we have really been emphasizing on multi-sectoral collaboration. We need to bring all the stakeholders on board in order for us to make sure that we offer very, very comprehensive services through the NCD ICC. This is our umbrella body. We have been able to bring various players, the academia, the professional bodies, including the private sector. And this in our country is the only way, and we treat this as a major priority. And it is one of the key issues or one of the key roadmap toward achieving quality service for cardiovascular diseases in this country. What are the challenges we are facing? Of course, we have a myriad of challenges, including increased exposure to risk factors, especially among the younger generation. When it comes to alcohol consumption, tobacco use, sedentary lifestyle, unhealthy diet, I think these are major risk factors which we really need to address through multi-sectoral approach. Likewise, we have our health workers have limited capacity to manage CVDs in this country, but we are putting all efforts to make sure that we capacity build them appropriately. We have limited health products and technologies for management of CVDs, but I'm sure this one we are addressing. There are also a lot of there's limited resource allocation. We have a resource gap of 94%. We only have 6% of all the resources we require in this country to handle NCDs. And I want to believe that is the same for CVDs. Paucity of data, very little data. But maybe very, very soon, once we finish what we are doing as a ministry, the issue of paucity of data will be a thing of the past. Okay. However, one of the things we really need to conduct when it comes to management of CVDs in this country, particularly for Ministry of Health, we need to embrace a lot of research surveillance so that whatever decision we make are evidence-based. Last but not least, way forward, of course, we need to implement the NCD strategic plan from the highest to the lowest level. We need to revise, relaunch, and disseminate cardiovascular guideline. We also need to strengthen community health units at the primary healthcare facilities so that we are able to do screening and have early detections of CVDs and also have appropriate referral pathways for them. We also need to promote CVD-related research. I think I've also alluded to that fact. And not also to forget, we need to improve on our data registry, establish centers of excellence, among many other things. I think I want to stop at that. I know I've gone beyond my time. Thank you very much for listening to me. And we shall maybe meet again during the plenaries when I may have one or two issues to respond to. Thank you very much. Back to you, the coordinator.
Yeah, thanks, Fantas, for that very elaborate presentation of what the ministry is doing. Very often we live in different silos and people don't know what the other side is doing. And it helps to highlight these things because we have a lot to do in common. So we're shifting gears. Usually when we talk cardiovascular disease globally, generally it implies disease at the end of the age spectrum. And it generally implies atherosclerotic disease, degenerative diseases. However, in our environment, we still have a large burden of rheumatic fever and rheumatic heart disease, which is probably one of the more expensive cardiovascular diseases to manage. It is an entirely preventable disease. So we in the Pan-African Society of Cardiology have really prioritized not just the control, but the elimination of rheumatic heart disease. So going to present rheumatic fever and rheumatic heart disease is Dr. Amy Okello, again, a colleague, a friend, one of the really rising young stars of cardiovascular medicine in Africa. I've had the privilege of interacting with him and seeing him mature. He is the director of the Uganda Heart Institute. He is an interventional cardiologist. And with respect to today's presentation, he is actually the chair of the task force for rheumatic fever, rheumatic heart disease of the Pan-African Society of Cardiology. So he is very involved in research and is going to focus on updates of recent, research work on rheumatic fever, rheumatic heart disease in Africa. Welcome, Amy.
Thank you very much, Professor Gola, for your kind introduction, and thank you to the organizers for inviting me to take part in this very important meeting. So that's a brief outline of what I'll go through. I'll briefly review the burden of rheumatic heart disease and look at some of the important studies that have taken place in Africa over the last decade or so. So as a reminder, rheumatic heart disease is a long-term complication of recurrent attacks of rheumatic fever. The long-term complication commonly is damage of the heart valves that unfortunately in our environment will present with complications, usually heart failure, arrhythmias, maybe even stroke. And the rheumatic fever is really triggered by untreated group A streptococcal infection of the throat in communities that tend to be disadvantaged and overcrowded. Genetics, host genetics is thought to play an important role in the pathogenesis of rheumatic fever and rheumatic heart disease. So the incidence of acute rheumatic fever, which is shown in blue, tends to be highest about between 5 and 15 years of age, whereas the prevalence of rheumatic heart disease, which is a long-term complication, shows up either in late teens or in early 20s. So as of 2020 global burden of disease, rheumatic heart disease now affects about 40 million people worldwide. The blue dotted lines show you where the prevalence is highest. As you can see, Sub-Saharan Africa, Southeast Asia, and South America. And there's about 300,000 people dying annually. Unfortunately, most of those people dying tend to be in the developing world. And as I said earlier, and most of this is because most of our patients present late. This graph shows you what we looked at in the Uganda Rheumatic Heart Disease Registry, which started in 2010, comparing interventions from 2010 to 14 and 14 afterwards. Usually there's no big difference unless you provide surgery, which, as we know, is not widely available to most people. So what has been happening about rheumatic heart disease in Africa? Most of the early works on rheumatic heart disease started in 2007, driven by most of our senior colleagues, Professor Elijah Ogola, and seen in that photo with the late Professor Bongani and many other colleagues who sat in the Drakensberg area in South Africa and redeveloped one of the first concepts on rheumatic heart disease after the World Health Organization efforts had come to allow. And this first paper was a uniform plan for the control of rheumatic fever and rheumatic heart disease in Africa. Their sub-program was one of the first ones that reignited efforts to prevent rheumatic heart disease and to conduct research on rheumatic heart disease in Africa. That Drakensberg Declaration led to Remedy, which was a multi-center registry that took place in 14 countries, mostly in Africa, but also in Yemen and India. And again, most of our senior colleagues were part of this. And Remedy, this is just the numbers that were contributed by the different countries. You can see Kenya there contributed about 316, Uganda 311, Malawi, Ethiopia. Remedy taught us many things. One, that the prevalence of rheumatic heart disease was high, and that most patients with the disease were in their late teens or early 20s, and that most patients presented with a complication at first diagnosis. You can see heart failure on this graph at 33%, and really a quarter were in New York 3 and 4 heart failure, and they also had stroke, and most of them had more than one heart valve involved. Again, requiring heart surgery that is not affordable to most people. And also when the follow-up study of Remedy was published, we saw that mortality was high, about 17% annually, and the average age of death was 27, which is pretty premature. Yes, so some of the other works then that continued from that was to look at the genetic susceptibility to rheumatic heart disease. And I've used this schematic that was drawn by Jonathan Karapitis and published in the Lancet, that's showing you the continuum from group A strep in a susceptible host to acute rheumatic fever and rheumatic heart disease. And earlier on, Mark Engel from the University of Cape Town had shown us that there was a strong evidence of association, family association, and this is demonstrated through a systematic review among twins, showing that there's a strong evidence of association. This led again to a collaborative study called the RHD Gen that was again done across Africa. It was aimed to build a network for phenotyping of rheumatic heart disease. And this was sponsored by H3 Africa, which was a Wellcome Trust funded grant to identify genetic variants affecting susceptibility and resistance to rheumatic heart disease. It ran from 2013 to 2017 and targeted some 3,000 adult cases with echo-defined or confirmed rheumatic heart disease. And then there were 3,000 controls, again, 8 countries from across Africa, Kenya, Uganda, South Africa, Sudan. And we were able to perform a genome-wide association study. And as you can see, the countries there, results were interesting, which again was in line with what we had seen before, but previous studies were mainly HLA studies based on the major histocompatibility complex. And here I was showing that on chromosome 11, there seems to be a gene there, RS1219406, which is thought to be a susceptibility gene. And that Manhattan curve, you can see the circle. And this particular area on chromosome 11 is also associated with autoimmune traits, including lymphocyte count, atrial fibrillation, and rheumatoid arthritis. So a lot of buzz around genetic susceptibility for rheumatic heart disease, and there's continuing work to further see. And this has a lot of importance when you look at point-of-care tests and screening for people who are vulnerable and needs to be protected in preventive efforts. Yeah, that's just the conclusion from the study, and it was published in the Journal of American Medical Association earlier this year. The other aspect of rheumatic heart disease work has been looking back at acute rheumatic fever, which is the main step in the whole process. And this was done here in Uganda, where we went back. Why? Because just to look at acute rheumatic fever, when you look at the earlier chart that shows the peak incidence usually between 5 and 15 years, and rheumatic heart disease, tends to be diagnosed much later. And yet we don't see as many cases of acute rheumatic fever as those of rheumatic heart disease. And so there's been a question, where are the cases of rheumatic fever? Are we missing them, or is rheumatic fever presenting differently? And so we sought to understand the gap between acute rheumatic fever and rheumatic heart disease. And those are the two aims: to characterize the clinical, lab, and echo features of acute rheumatic fever in a low resource setting, and especially those that distinguish between acute rheumatic fever positive and rheumatic fever negative referrals, and further to evaluate the extent to which certain characteristics, especially those who are distinguish between acute rheumatic fever positive and rheumatic fever negative referrals, can be used to improve the specificity when full diagnostic testing is unavailable. And so we looked at children age 3 to 17 who presented with fever or history of fever in the last 48 hours, and either monoarthritis, monarthralgia, polyarthritis, or polyarthralgia. We also carried out echocardiography as a point of care test, and we're looking for cardiac murmur suspicious of a mitral regurgitation or aortic regurgitation with or without signs of acute left heart failure, as you'd expect in carditis. And we excluded cases with clear alternate diagnosis at the time of presentation, especially typhoid, sickle cell. And these are the results. This study took place in 2 districts in the north and west of Uganda. And those are the populations at risk at the time, about 400,000 each. The incidence of acute rheumatic fever in the north, that is in Lira, was 27 per 100,000 compared to 14 per 100,000 in Barara. That's in the west of the country. But that's if we use the extended criteria to define a special category called possible acute rheumatic fever. And then when we looked at the definite acute rheumatic fever diagnosed based on the Jones criteria, which is the standard of care, we saw that it was 20 in Lira versus 12 in Barara. When we combined this, which is the usual practice in the clinic, we ended up with 47 per 100,000 in Lira and 26 per 100,000. And the 47 was fits in the definition for a high incident area, showing that rheumatic fever is indeed present in the community, and people are just being missed either from health system issues or health seeking behavior of those who are sick, or the disease may be presenting a little differently than that defined by the Jones criteria, and the need for extended diagnostic catalog. This study was published in the Lancet Global Health early this year. One of the other advances in the last 10 years has been the development of the concept or the discovery of the concept of latent rheumatic heart disease. We have known that rheumatic heart disease takes long to develop after rheumatic fever, but we didn't know that there's an early stage for latent rheumatic heart disease that is potentially reversible if diagnosed on echocardiography and the patient is placed on benzocaine penicillin, which is easily available and cheap. So, the evolution of this new concept of latent rheumatic heart disease has encouraged us to promote echocardiographic screening. And as you can see in this pyramid, we see that below the red line, that the majority of patients in the community or children in the community have latent rheumatic heart disease, that is either clinical definite rheumatic heart disease or subclinical. These are children playing around with changes on their heart valves, and because they don't have features of heart failure, no one is bothering to check them. The few that come to the clinics that all of us see are the few at the peak of the pyramid who come with severe valve disease, as we saw at the beginning, requiring heart surgery, and most of them unfortunately die off. So we sought to answer one of the important questions, whether early detection of latent rheumatic heart disease through echocardiography and initiation of secondary antibiotic prophylaxis would lead to improved outcomes. And we ran a clinical trial between 2018 and 2020. We screened some 100,000 children. Out of those, 916 met criteria for the trial, and half of those were administered once monthly benzocaine penicillin injection, and the other half was not given penicillin. And you can see this took place in the Gulu region in northern Uganda. School children, you can see during their screenings. And we gave a total of 10,900 injections. Adherence was over 90%. And as you can see in the results, when we looked at our primary outcome, which was the number of children who had progressed or worsened from their lesion at baseline, we see that only 3 out of 399, which is 0.8%, in the penicillin arm versus 33 out of 400, which is about 8.3 in the control arm, progressed or worsened. And you can see the risk difference there, with a very strong confidence interval. And then when you look at the children who stayed without penicillin, again, about 16 out of 33 worsened compared to the other arm. So basically showing that penicillin was, penicillin significantly impacted or halted progression of latent rheumatic heart disease. Because this was just a 2-year study, and we are carrying out continuing cohort studies to see what happens at 5 years as a natural cohort. And this study was published in the New England Journal last year. Finally, the Invictus study, which was another multi-center study that took place across many African countries, which was targeted at investigation of rheumatic atrial fibrillation using vitamin K antagonists, in this case warfarin, and then rivaroxaban or aspirin studies. The hypothesis here was that rivaroxaban would be non-inferior. We know rivaroxaban has been licensed for venous thromboembolism and for non-valvular atrial fibrillation, but it hadn't been tested before in valvular heart disease, in valvular AFib. And so the hypothesis here was that rivaroxaban would be non-inferior to VKS for the prevention of stroke or systemic embolism in rheumatic atrial fib. It was a prospective randomized parallel group open label study. So rheumatic heart disease diagnosed by echo, this is the criteria, participants aged 18 and above, and who had increased risk of stroke, defined by Chad's FAST score of over 2, moderate or severe mitral stenosis, the valve area less than 2, or those who had left atrial spontaneous contrast, or left atrial thrombus, or documented atrial flutter at the time. It was a 1-to-1 randomization, and rivaroxaban 20 milligram was administered daily. If someone had a creatinine clearance over 50, or those who had creatinine clearance below 50 but above 15, were given 15 milligrams once a day. Those who had creatinine clearance below 15 were excluded. Warfarin was any warfarin on the market approved for use in the participating country. In our case, was the National Drug Authority approved warfarin, and we had point of care testing for INR monitoring in the community, and to maintain between 2 and 3. Important results. This was released at the EAC, European Society of Cardiology meeting end of August. As you can see, the primary outcome was a combination of death, stroke, myocardial infarction, or any other deaths. You can see the rivaroxaban group had 8.2% events versus 6.5% in the warfarin group. Very strong hazard ratio there. The relative risk was much higher in the rivaroxaban group. Again, when you look at death on its own, there are more deaths in the rivaroxaban group compared to this in the warfarin group. And even when they separated ischemic stroke, you can see 1.1 versus 0.7. And the curves, as you can see, started separating after 18 months. And when you read the article, you see that the curves started separating as the higher number of participants achieved over 60% of time in therapeutic range. So you can see this person, rivaroxaban, this is the composite, this is the primary outcome, the composite of stroke, systemic embolism, myocardial infarction, death. And then even when you separate systemic stroke or systemic embolism and also death separated, still, you see that the events started going up in the rivaroxaban group versus the warfarin group. And again, this was published, and there are many investigators from across Africa, I see Bernard Victoria from Kenya, and many other colleagues from the region. So what are some of the take-home messages regarding rheumatic heart disease work in Africa? That there's continuing work on molecular epidemiology of group A strep. I didn't talk much about this in my presentation because of time, but there's a lot of work to sort of develop a molecular database of group A strep, to get ready for a vaccine. Eventually, I think we'll have a vaccine trial against group A strep. That's at the community level. And of course, based on our findings in Lira in northern Uganda, there's a strong case for acute rheumatic fever surveillance. So this provides sort of, a lost opportunity currently that it provides a very easy intervention stage if we are to, do secondary prevention of rheumatic fever, rheumatic heart disease. And of course, echocardiography screening, as we've seen for latent rheumatic heart disease, and secondary prevention with benzodiazepine penicillin depends on this. So very, very strong point for echo screening, because we can only do all the things that we've done if we know. If the children are playing at school and we wait until they develop complications of rheumatic heart disease, then it's too late. But if you find them earlier, maybe easier and cheaper to intervene. So that's the follow-up point there, that there's a strong case for secondary prophylaxis for latent rheumatic heart disease. And finally, from the Invictus trial, that warfarin as a VKA is still the best in rheumatic atrial fibrillation. Very strong case from the composite, but also against death and ischemic stroke. And we have seen an unexpected reduction in cardiac mortality. I hope you get time. There are many explanations for this. We think that patients on warfarin had more engagement with the health system because of the INR monitoring. And of course, they benefited from better care than those who had rivaroxaban. But there are people who believe that, maybe warfarin has an undiscovered, role, cardioprotective role, but that's for us to find out in the future. Thank you very much.
Thanks, Amy, for that. I think that demonstrates to the audience that it is possible to do cutting-edge research in Africa addressing our very specific issues. Nobody in Boston or London or Amsterdam is ever going to do this work for you, because it's not their problem, it is our problem. Thank you very much, Amy. So we'd agreed that you would take a small break so that you reduce your risks of DVT and all that. I'd initially suggested 10 minutes, but we are running late. I think we are about 15 minutes late. So I suggest we take a 5-minute break, stretch your legs, take a glass of water, what have you, and we reconvene at 3:35 for the next talk. Very interesting. We'll have 2 consecutive talks focusing on pediatric issues before we go on to the others. So see you in 5 minutes time. On the dot. Welcome back. I hope you enjoyed the brief respite. So as I sort of mentioned earlier, often when we think of cardiac disease, we think of the older adult. But there is a big burden of cardiovascular disease in the younger age group. One of them is rheumatic heart disease, which we've just heard about. But then there's the whole of congenital heart disease. So the next 2 talks are interrelated, so I'll introduce them together so that we save time. So giving the first talk is my friend and colleague, Professor Christine Joey, who is a pediatric cardiologist. I call her the godmother of pediatric cardiology in this country. Her passion for the heart health of children is remarkable, is unmatched, and she's contributed a lot to the development of pediatric cardiology in this country. So the first talk will be on the developments of pediatric cardiology services in Kenya. Now, pediatric cardiology is largely structural congenital heart disease. Therefore, the definitive management is the correction of those abnormalities. Therefore, cardiac surgery plays a very, very important role in the management of congenital heart conditions. So after Professor Jovi's presentation, we'll have Dr. Mark Awori, who is a pediatric cardiac surgeon, to give us insights into the development of pediatric cardiac surgical services in Kenya, another colleague and friend, and a co-faculty at the University of Nairobi. So I plead with the remaining presenters, we are sort of running short of time, if we can try to stick to that time. So it is my pleasure to welcome Professor Jovi to give her presentation. Christine, the floor is yours.
Thank you, Professor, for allowing me to make this brief presentation. Basically, most of it, as you said, will come from some of the experiences and others, I think, from what we have. I'm trying to get my video to show, but it isn't, so maybe I'm glad to be incognito. And when we talk about the developments of the services in cardiology, then I think we go back a little bit to start sharing. It doesn't like to move. So let me try to see what I'm not doing correctly.
Sometimes what you do is just unshare and share again and see if that works. If that doesn't work, you can move it and remove it from presentation mode. That sometimes helps.
Okay. Thank you. So basically, when we talk of pediatric cardiology, there's usually a scope, and this is really a wide range. And as you can see from the right side, it starts from the fetus to the neonate, to the infant, to the children, adolescents, and the young adults, depending on the definition of the young adults. And basically in our country or in our region, the pediatric cardiologists still take care of congenital heart disease in the adults, even if they are 58 or 60 years. So that still is part of our domain, and that's the kind of practice we have here. So basically you can see that it is a broad field of practice and a broad area for academia, and it includes a wide range of activities, including the imaging. And in the imaging here, we talk predominantly, we had echocardiography in all its array, but then now we also have additional magnetic MRIs and CT scans coming in for some of the cases. This is developing, not at the pace that the international arena is, but it is developing, and I believe it will be taken up by a lot of young Turks and will be much better than where we are now. Cardiac catheterization, basically, historically, is what we started with and then moved over to echo. So the cath lab has been with us since the 70s, and the interventions started coming in. Initially, basically, it was just for diagnostic. We then do have electrophysiology and exercise physiology, which is also coming up and developing. The other aspects which the pediatric cardiology enhances is the intensive care unit and preventive cardiology. And I remember when we started, the cardiologists had to do a lot of intensive care, and you can see how gray and difficult it was. Thanks to the recent developments, this has now been captured by the intensivists, and we can now do our jobs. Preventive cardiology is still there. Then we had the adult with congenital heart disease, which we still have, and I'm sure a number of adults are now coming to appreciate the adult congenital heart disease, and maybe this will be taken away from us. The basic sciences are still there. We've just had a lot on acquired heart disease, predominantly rheumatic, but we also do have some specifics of acquired heart disease that are actually unique to this region. We have the heart in rickets, the heart in malnutrition, especially kwashiorkor, the heart in some of the unique tropical conditions like sickle cell and maybe other infective conditions, and that also the pediatric cardiologist finds themselves dealing with. Just a few basics on the milestones. In the 70s, most of what was there was the bedside teaching and clinical auscultations. And within the surgical aspect, because that goes along with the pediatric cardiology, we did have a lot of PDA ligations and pericardial surgery. In the 80s, we then had our monoplane cath lab going on, and we also had our black and white Doppler 2D echocardiogram, and a lot of diagnosis started in, and echo started taking over from the cardiac cath. And later on in the 90s, there was an improvement in the echoes, the echocardiogram machines, and these services in the early 90s and the 80s were only at the National Hospital. And that is where we also had our first C-arm cath lab with some developments. Then in 1994, Mater Hospital managed to get a C-arm modified cath lab, and thereafter, a lot of centers have now standalone cath labs. Nairobi alone has almost 10 cardiac catheterization laboratories. They're close to 10. When I counted them, there were 8. So I said I could be wrong, maybe one is coming up. And so that's what we have. And other counties have also followed in. Mombasa has a cath lab, and Eldoret is also planning one. I think they've already put it. And so there's some developments and milestones that are there and which we are happy about. So from 2000 to date, we have seen a lot of improvements in echocardiography. And these improvements include not only the digitalization of these echoes, but also the fact that they are more portable. And so we have had to move out on individual basis and on collective basis to do echocardiograms out. Then later on, within the last 4 or 5 years, we've had echo machines which are embedded within the ultrasound, and a number of adult echocardiographies now can be done in centers outside the main city, Nairobi and Mombasa. We also have advances in ICU and in monitoring, and also in the training of personnel. And this initially was with the support of MTC, but other hospitals have also taken into training their own ICU personnel, especially the private sector, and they've taken it very well. And now a number of intensive care centers are developing. And so you can see a number of cardiac programs also seeping in where the intensive care is developed. And in terms of consumables, we have better supply in terms of what is available within town. Long time, even if you had that money and it was not available, it was very difficult to get. The consumables are becoming variable and easy to get. And so I think the program and the milestones are improving, and I'm sure with more personnel joining pediatric cardiology, this will even be better. So let us just look at the imaging and what are the progress that we've had in terms of imaging. Initially, at the Kenyatta National Hospital, most of the echoes were shared with the adult program. And as you know, adults will always love themselves. So pediatrics only had 1 day to do the echoes, the rest became the adults. Then we struggled and got maybe 2 days, Tuesday and Thursday. And finally, now we have our own dedicated room with our own dedicated echocardiogram at the Kenyatta National Hospital, which is the main hospital providing the services to a wide range of patients. And so now there are a lot of people who are now trained to do echoes, and with MTC, there's been a role on trying to put in some more training. The pediatric one didn't pick as much, but it is moving, and I hope it will improve. We've also had more versatile echoes. We now have handheld echoes, which you can move around with the small gadget. You connect it to your phone, and you can do a very quick echo, see the 4 chamber and see what's wrong. We also have the portable echoes in their various ways. And within the main hospital, we have echoes dedicated to units. So you have the intensive care unit with this echo, and the newborn unit with its echoes. And so you find that these services are getting more available, and it's a shorter time now to have a patient examined and echocardiogram rather than the other times when the bookings were 2 weeks and more. So those are some of the kind of improvements that we've seen within the echocardiograms. We also at the Kenyatta National Hospital have a dedicated line whereby the bookings from the peripheral hospitals can be done. So you don't have to come make a booking and then come another day. The doctor responsible connects with the cardiac unit, and they make the bookings. And so these patients have a one-time touch and the recommendations given, and it's opened up to better management of these patients as a referral facility. And we also have made additional strides in echo, in that we can do some bedside echoes, and we can also do bedside interventions whereby they are echo guided. So the echo guided pericardiocentesis is possible and is very quick, and that has negated the need to come to the unit for a pericardiocentesis. Unless the patient is unstable, then you bring the patient to the unit, or unless the child is small, then of course you bring the child to the unit. Otherwise, for stable patients, we've managed to do echo-guided pericardiocentesis and echo-guided balloon atrial septostomy, especially in the newborn unit where the machine is there, and all you have to do is to connect with the cath lab, get the correct catheters, and the procedure goes on. So some of these are the strides, additional strides that we've had in terms of echocardiography. Move to cardiac catheterization, and the cardiac lab, as you can see, is a lot more complex. We started having it within the country in the 80s, and that started at the Kenyatta National Hospital, then the Mater Hospital, then Nairobi Hospital, then later on Aga Khan and other hospitals have come in, and now the cath lab the cath lab now has even extended to other parts of the country, and other facilities are also thinking of putting in the cath labs. And so this will, I believe, expand the cardiac services within some selected countries. And most of the lab has a radiology console, a hemodynamic console. I don't have my pointer. A hemodynamic and an anesthetic console, and this is where you look at the monitors, and we have the main structure and then the consumables, and basically that is what a cath lab looks like. It's a small mini theater. When things go bad, you can intubate your patient and continue with whatever you are doing. And this is part of a C-arm, and that's what is mainly within the country. In most of the cath labs, it's usually a C-arm. A few centers have biplane, but I will leave it at that. This historically is what happened when we started in 1974. That was the first cath lab. The second one that we found me around, and then finally we got another brand new still within the C-arms. And Mata came in 1996 with a very small but easy to use, and which can also be, this technology can still be done within the smaller peripheries wanting to start a cardiac unit or a cath lab. Then Nairobi Hospital came in, and we have the current hospital, Aga Khan Hospital, Nairobi West. MP Shah is the latest, and Moi, I'm told, is already in position. So we can see that there are now strides and developments in terms of cardiac catheterization, because that helps in a number of diagnostic and interventions and improves the cardiac work. So some of the procedures that we can do within the catheterization lab includes diagnostic and therapeutic. Diagnostic for simple congenital heart diseases, where we the pressures and decide on how operable the patient is. We also use it for diagnosing complex diseases. Myocardial biopsy, we've not done a lot of it. We have the biopsy things, but it's not a very common procedure, but if the facility is there and the knowledge is also there. In terms of using the cath lab to treat conditions, rarely now will we send doctors at Kenyatta to the theater, except for very large PDAs and babies. Those will still take. Atrial defect and VSDs are now treated in the lab. So are the coronary fistulas. And I say these are done with good results. And we were surprised that our work in VSDs peaked and surpassed the work of septal defects locally. And I think we've presented this data at the Kenya Cardiac Conference, the last cardiac conference, and we are working to show it to the international forum. We thought the devices were going to be quite expensive, but it hasn't, and relatively is affordable even for units which will hope to start their procedure. This is okay. Valvuloplasties is what we start learning from. We start with pulmonary, and pulmonaries, which are very common, 10% of congenital heart disease. So there's a lot of work that can be done in this area. And this is where when somebody comes for cath lab, this is the lesion we start, and thereafter we move on. And so in terms of valvuloplasties, we have pulmonary and aortic. Pulmonary is more common, fewer aortic valve stenosis, and stenting and dilatation of coarctations, yes, and a few lesions that are on and off done. We also do valvuloplasties for rheumatic heart disease, especially the mitral stenosis. That's in the juvenile patients, and even in the older patients where the pathology allows, and also in mixed valvular disease where you can have mixed. Most of those, sometimes we prefer to have them done because most of the procedures for rheumatic heart disease, whether you do surgery or not, or valvuloplasty, is not curative. All of them are palliative procedures. The main thing is to stop the rheumatic fever itself, and that is the only. Once it has come in, most of these procedures are palliative. And these are just a few pictures to show some of the this is a small patent ductus arteriosus. The kind, if you opened to try and close it, by the time you open, you will not see it. So you look around and you don't know which is the first. So most of these procedures are best treated in the cath lab, and we treat them using either the coil or And this is a demonstration to show how we close the atrial septal defect. We cross from the right to the left, then we come with a device from the left and move it down across the septum using the imaging and also echo, and we have the device in position and the patient is ready to go home the next day. So that is atrial septal defects that are done, and a number of them have been done both at and Mater Hospital. This again is just maybe just how the procedure is done, and then later on it's confirmed by echo to see that the position is adequate and is not impinging on the valves. And we do that before releasing, and once we are happy, then we release the device. This is a step-by-step approach on how to close the ventricular septal defect, either from the aortic end and some from the vena cava. So this is from the aorta, and so you come with a device, you look at it, and you're happy with the position, you release the device, and you can see that the device is closed, and most of that little one will disappear very quickly. So these are other types of ventricular septal defects. We're now coming from the inferior vein, and we cross it from the right side, and they do without any shards, and we are quite comfortable. And these are just a few data just to support what we've done, especially for the ventricular septal defects. Most of them were perimembranous with a few muscular. I haven't seen where I put the total numbers, but we had few small ones, and most of them were large, more than 6 millimeters. And so you can see most of these patients being saved from the knife. They also had associated lesions, which some we had to deal with, like PDA and ASD and atrial septal aneurysms. And these were our results. This is a very shortened slide just to show what we did. And I think these are probably the numbers that we did, and most of them are young children between the age of 5 to 15 years. In terms of we've done this for pulmonary stenosis, and it's amazing where these patients have come from. We are seeing now with improvement in referrals that we are having a lot of pulmonary stenosis, mild, moderate, critical. It's amazing where they've been hiding, but the colleagues outside there have now managed to pick them. And at the Kenyatta National Hospital, I can tell you, we get BC up to quite late, trying to sort out these patients, and it's very rewarding. Aortic stenosis is not as common. Coarctation also is not as common, but when they are picked, we do deal with them, especially both coarctation and pulmonary stenosis. Those are the most common congenital diseases that we deal with. In terms of acquired, mitral stenosis remains the commonest lesion, followed by aortic stenosis. But we've had mixed valvular disease, either mixed mitral and tricuspid stenosis.
Christine, may you begin to wind up? Unfortunately, I'm also a timekeeper.
Thank you. And that is coarctation of the aorta. And those are coarctation in the older ones, and most of those we stent. Some of these are the complications we see. The devices can embolize. This was a VSD gone wrong. We managed to pull it back and put a bigger size. So you don't leave anything that you didn't find there in the patient, its position. And of the acquired heart diseases, again, rheumatic mitral stenosis is one of the commonest lesions. And this procedure was developed at the Kenyatta National Hospital. And we have perfected it, and we still use it up to now. And a number of centers have also taken it. This is the double balloon using the system. So we're proud to have this system as one of us. I think we passed it in 1994. And these are probably what we've seen for mitral stenosis. We really get very good levels. Once you can get between a 3 to 4-fold rise in the valve area, then you give the patient time, because you don't want to give the patient mitral regurgitation. I think that comes to the end of my topic. The challenges are there. It's not a walk in the park. The training of pediatric cardiology is a highly skilled profession, and you're serving a very vulnerable group of patients. And it has to be driven by accurate diagnosis so that you plan a concise management that takes time to attain. It requires greater resource allocation, which cannot be left to the public sector only. And so the private sector has also come in a few of these conditions. And it is multidisciplinary in that we cannot have it as a standard service. Requires a lot of collaboration, and we only got better when our ICU and anesthesia got better. And we realized that nutritional services are also as useful, but those are some of the challenges that we've had. Thank you, and have a Merry Christmas.
Thank you, Christine. So we'll go straight to Dr. Makawari's presentation on pediatric surgery. Cardiac surgery.
Yes. Thank you. I'm just getting the image up. I hope you can see my presentation.
We saw it, then it disappeared. So
I hope you can see.
Oh, yes.
Can you see it? All right.
Yes,
Thank
yes,
you.
I can
So,
see it.
great. So it's late in the afternoon. So I'll ask everyone, wherever they are, you can just stand up and do a stretch. This will be a short presentation. So just stretch it out, breathe in so that we can maximize our intake. That's right. So welcome. We're just going to talk about briefly about pediatric cardiac surgery, more particularly congenital cardiac surgery. We're going to look at it with an African perspective, but we'll use Kenya as our I wouldn't say guinea pig, but I'll say as our looking glass. So this is a surgical kind of approach. So bear with me, I'm going straight to the nuts and bolts. Really, the problem with congenital heart disease can be summed up in this slide. Before we had surgery, look at that, only 20% of children who are born with this reach their first birthday. That's pretty bad. So we needed to do something about it. Enter 1953, when the first open heart surgery on the heart-lung machine was done, 1953, and Africa was not far behind. In 1958, so only 5 years later, the first open heart surgery was done. This is in South Africa. Look at the difference. Instead of having only 20% of your kids reaching the first year of life, now you have 90% reaching adulthood. It was a big jump. It was a game changer. Of course, as my colleague, Prof. Has said, the intervention side of things is also contributing to this. So things that used to be done by surgery, a number of them are being done interventionally. But the aim is look at what the intervention does. It really helps. Now, this is a very important slide because you can't just copy and paste what the developed countries are doing. So what do I mean? When you talk about congenital heart disease, two things you have to have in the back of your mind. The pathology as it progresses, sometimes or a lot of the time, it makes the patient inoperable. So even if they're still alive, you might find that they've reached a stage where it's either too dangerous to operate or operation's not going to help them. And this is an illustration. This is a collaborative study between the University of Nairobi and the Children's Hospital in Seattle. And we looked at truncus arteriosus. Now, if you look at the little graph on the right, it's a composite graph. And you can see the light gray. I know it's not so clear, but the light gray is the natural history curve. So a lot of these kids, 60% of them have died, within the first month of life. That's why for trunkers, we talk about you need to operate as a neonate. But my point is, by the time they reach 5 months of age, you really have to think whether you're going to operate, because the natural history curve has flattened out. And although it doesn't show it here, it remains flat till all the way out to 15 years of age. And the black curve superimposed is the surgical curve. And it's it's more or less lying on the natural history curve. So you have to ask yourself, are you going to operate? And this is the challenge in Africa. Our patients come late, and you can't just copy and paste. You have to really understand the natural history, and then you have to understand what can be achieved by your intervention. So what's the situation on the ground? In 2007, we published this paper. We were looking at, how are these children being handled in Kenya? So we coined the phrase, the management pathway, and you can see it there. And the idea is people are diagnosed, then they go for intervention or surgery, and then they are followed up. That's the pathway. So it's diagnosis, intervention, follow-up, and it's often a loop. But there are these other factors which affect how well you diagnose, how well you intervene, and how well you follow up. And it's important to appreciate that these affect your service. So what did we find when we looked at the situation in 2007? So in 2007, the mean age at which congenital heart disease was first suspected sorry, I'm misleading you. Let's look at this. I think that's erroneous on that slide. Have a look at this. So the mean age when a patient was referred to the pediatric cardiologist was 16 months of age. And you can already see that a lot of children will have died by that, right? So that was one of the main things we found in 2007. Not only that, it's not included here, it's in the body of the literature. We found that most of the kids didn't get surgical intervention in time. That's the second thing we found. And then finally, the third thing we found was and these kids were being lost to follow-up. So enter 2022. Now in 2022, things have improved. So the age at which the condition is first suspected has reduced. So these are erroneous figures. Look at the middle line. So instead of having your echo at about 16 months of age, it reduced to 10 months. So there's improvement over 15 years. We don't have all the data on whether they're getting the surgery and follow-up. That is ongoing. But at least we can say in the 15-year period in Kenya, things are improving. We've dropped the age at echo diagnosis from 16 months to 10 months. At least we're now under the first year. So improvements are being made. Now, how big is the problem? This is the challenge. If we go by the data, we're saying there are 16,000 children born every year in Kenya who have congenital heart disease. So what are the existing solutions? Well, traditionally, we've referred patients abroad. We've had what we call surgical/interventional safaris. And then finally, we operate or intervene at home. So what are the outcomes of these solutions? Well, there's no question about it. When you refer a patient abroad, they get helped. Likewise, when you have people coming from out and doing procedures, whether it's surgery or intervention, patients are helped. There's no question. But the issue is too few patients are helped. And this kind of solution cannot serve the nation. So what's the way forward? So we need to look at the only other outcome or the other solution, which is solution 3. So what do we have on the ground at present? Well, I know there are many places where they do surgery, but there are probably about 4 institutions that regularly perform surgery on kids. I mean that, you know, if the child needs surgery, the local team can be mobilized and they're operated on. So 1 is government, 3 is private, or 3 are private. Now let's look at the government one. It's actually Kenyatta National Hospital, and it's been faithfully serving Kenyans for many years. But we need to look at something that might not be so obvious. That unit in Kenyatta National Hospital, it's 1 ward, Ward 4B, 30 beds. And if you look at the breakdown of the workload, 30% of the workload is chest trauma. Then you have peripheral vascular disease. Then you have open heart surgery, which is primarily valve replacement and congenital. Then you have abdominal, aortic aneurysm, and C esophagus. These are the big 5. And they're 80% of the workload, 30 beds. So what does it look like for the children? At best, and I'm saying at best, the pediatric cardiac surgery service represents 7% of the patient load at KNH. That's Ward 4B. That translates to roughly 40 open hearts, pediatric in a year, congenital. What does that look like for the surgeon? Maybe 5 to 6 pediatric open hearts per surgeon per year. This is the reality on the ground. The children are not getting the service they need. So what's the way forward? What's the way forward? The way forward is to consider the financial situation of the country. There's no way around it. And this is a very interesting schematic. Most of Kenya and Africa are in the middle and low income category. Very few of the country, 5% to 10% max, are in the high income. So the majority of people are in the middle and low income. What does that look like when you compare it with the rest of the world? This is a very interesting schematic, and we're coming to the end. This is a graph that charts along the horizontal axis. It charts the GDP per capita of a country. And on the vertical axis, the life expectancy. You can see where Kenya is. Our GDP per capita is roughly $3,000 US. Look at where the UK is. It's $42,000 US. Now, the UK, with all that money, which is roughly 14 times what Kenya has, is struggling to deliver universal healthcare. It does, but if you need your hip replaced, you still need to wait, all right? So even if no money is stolen in Kenya, I'm talking about no money, the reality is we still have limited resources. And that's a reality we need to think about and plan around. And it has nothing to do with all the money is being stolen and what have you. Even if no money was stolen, we still have limited resources. The good news is, though, almost all the countries of the world are moving up and to the right. That's correct. So they are moving, their GDP per capita is improving, and of course their life expectancy is increasing. So that's good news. Why? It means that this increase in national wealth should be put to good use. And I suggest it should be put to use in 2 ways concerning pediatric cardiac surgery. The state hospitals like KNH should progressively dedicate more of their resources to having a dedicated pediatric cardiac surgery service. So instead of, for instance, having everybody in 1 ward, we need to start thinking about specific days for children's heart surgery and eventually move to a specific unit. It can't be done all at once, but we need to start making strides. That's in the public sector. Now, as the country is walking towards more income, then we need to use the triple P approach, which has been used in Mata for a long time. And this is, we have philanthropic partners who give donations. We have public partners, that's the NHIF, and we have private partners who are the parents of the patient's families and friends. Now, this is how we can utilize a partnership between the public sector and the private sector. So the private sector can support the national pediatric cardiology service. So instead of thinking about it as a competition, you have children being operated on in public hospitals, but you also have children being operated on in private hospitals. And the funding is happening through the 3P approach. So cooperation is required as we wind up. Cooperation is required, right? As I've said, it's not a competition. We shouldn't feel bad if a patient is being operated in a private institution or instead of Kenyatta or vice versa. We need to be happy that we are serving the Kenyan population. Now, the key point I want to make is because we are short-staffed, we don't have resources all the time in different places, both types of institutions need to be they need to facilitate the flow of resources. We should not have silos. We should not we should not, ring fence resources and say this doctor can only work.
Mark, I'll request you to wind up, start winding up.
All right. So we cannot ring fence these resources. We need to have fluidity and think outside the box so that people and resources can go to where the patients are needed. The last slide, it's not pie in the sky. As Prof. Joey talked about the results in MATTER, and MATTER's been doing it for years. These are the results in a newer program in Gertrude's. And the comment I want to make is the patients we see at Gertrude's are patients who either cannot go abroad, they don't have money, and so clinically they're challenging, but also financially they're impoverished. But we are still able to operate on them and give them reasonable results. So in short, we need to cooperate and it's doable and we are moving in the right direction, but we just have to keep moving and keep going. Thank you.
Thank you, Mark. Sorry to harass you about time, and thanks for challenging current paradigms. We have to think out of the box because the challenge is big. So we'll move on quickly to interventional cardiology. We've already had an idea about interventional cardiology from a pediatric perspective, but the world of interventional cardiology is rapidly progressing out there. It started predominantly from coronary interventions and now into structural heart disease. So to give this talk, it's another good friend of mine, Mohammed Daylan. He's the director of cardiac services at the Aga Khan Hospital. He's an assistant professor of medicine there. He's also very active in PASCA. In fact, he's the head of our task force on interventional cardiology. So Mohammed, sorry that your talk is coming later than it should have, but please welcome.
Thank you, Elijah, and thank you for putting together such an impressive program. I've been following it over the last 2 hours from when Neil Poulter was presenting to up until now, and the talks have been really interesting. I'm unable to start the video. I think the host has to allow me to start my video, but I'm happy to proceed without sharing. There you go, start my video.
Just proceed, just proceed.
There you go. So there we are. And maybe I'll just dive in and try and give you a little walk through interventional cardiology, what I think is most important, particularly in Africa, which is essentially the saving of lives in the acute and emergency context. A lot of elective interventional cardiology remains important, but what I'm going to try and emphasize now is some of the challenges we face in Africa with dealing with these more acute problems. And I'll kick off with a case. A 49-year-old man with no prior medical history who presented with chest pain in our institution. The chest pain was of sudden onset, associated with a brief episode of loss of consciousness that responded to a thump to the chest and some basic chest compressions. 45 minutes later, so really within an hour of his episode of chest pain, he finds himself at the emergency room in Aga Khan University Hospital, where we're a resource-rich facility, so we were able to have already a system of care in place to manage heart attacks. The ECG is done within 10 minutes, and you can see somebody is excited because they've drawn around what they've identified to be the key finding on the ECG, which is the patient has both right bundle branch block as well as ST elevation in the anterior leads that progresses from V2 to V6. Now, the standard of care for management of heart attacks around the world is immediate intervention, including administration of drugs, and if possible, primary angioplasty. And of course, the meta-analyses of multiple randomized trials have compared primary angioplasty to thrombolysis, which is the alternative, and have consistently demonstrated, even in the earlier time zones, the superiority of primary angioplasty to thrombolysis. But this, of course, is in patients who present quickly to facilities where primary angioplasty can be offered quickly. And because this patient presented within what we in our institution call the golden hour, we were able to take the patient into the cath lab. This wasn't actually done by me, it was done by my colleague, Dr. Mzengunga, who many of you will already know. And the picture on the left-hand side is a picture of the coronary intervention that happened. So on the left-hand side, you'll be able to see the a missing artery, and on the right-hand side, you'll see that that artery has been recanalized, has been opened, and that myocardium has now been reperfused. And the reason why we do this quickly is because we want to save myocardium. But be aware that this is the end of a journey for the particular patient. The patient was resuscitated by his wife, brought in by ambulance, given drugs in casualty, and eventually arrived in our institution ready for treatment. In addition to this, the patient required drugs on discharge, and there was another lesion in another artery, and over a few hours later, the patient received a staged intervention to the left circumflex artery. So the anterior descending artery and the circumflex artery were diseased, and there was evidence of inflammation in both of them. One completely occluded, which was fixed immediately, and the other one, which wasn't completely occluded but was severely diseased, which was fixed 3 days later. And when you're able to get in and fix patients' arteries relatively quickly, then you can benefit from the good assessments on echocardiography, and you're able to demonstrate this patient has actually improved their, saved their myocardium. The ejection fraction on our estimation on this echo was in the 50 to 55% range, which is essentially almost normal. Now, prevention of heart failure is one of many targets for interventional cardiologists. Specifically, when we think about heart failure in Africa, we're thinking heart failure can be caused by rheumatic heart disease, and we had some presentation on that. And prevention of heart failure or management of heart failure and rheumatic heart disease by an interventional cardiologist will ordinarily include a combination of good quality imaging, followed by drug therapy, followed by, if necessary, intervention, either by balloon valvuloplasty to the mitral valve, or by specific interventional techniques to other territories. In addition to that, there may be a need for open heart surgery. Really, what you should be feeling is that an interventional cardiologist works within a team of people, some of whom are cardiologists, some of whom are cardiac surgeons, some of whom are clinicians and physicians, some of whom are part of the patient's family and infrastructure. In addition to managing heart failure in this context, due to rheumatic heart disease, of course, preventing heart attacks, more recently, managing high blood pressure using interventional techniques like renal denervation have come to light. So trying to prevent heart failure is an important development and process in interventional cardiology. And when patients develop heart failure, we can also offer treatments to prevent sudden death, like pacemakers, defibrillators, resynchronization therapy devices. And in the more expensive, higher end treatments like transcatheter aortic valve replacements, where heart failure may be caused by severe aortic stenosis, or indeed MitraClip, which isn't currently available in Kenya, but a technique to improve the mitral valve function in patients with heart failure associated with significant mitral regurgitation. But in addition to managing heart failure, we're also trying to prevent strokes. And sometimes interventional cardiologists will be able to prevent strokes by plugging gaps within the left atrial appendage or blocking passage of thrombus between the right and the left of cardiac chambers, which may translate into embolization into the heart. But of course, a lot of what we do is also focused on managing disabling symptoms and preventing arrhythmia. And I'll just sort of talk specifically about the two most impactful interventions that an interventional cardiologist can address. First one being an acute ST elevation myocardial infarction. In terms of quality adjusted life years, primary angioplasty for an acute MI and insertion of a pacemaker in a patient with complete heart block are two of the most impactful quality adjusted life year interventions that any clinician can offer in any field of medicine. Now, if we look at Africa, because that was the subject of my talk, acute coronary syndromes in sub-Saharan Africa have been relatively understudied. We're looking here at a systematic review published by my colleague, Dr. UoN-KNH, and you can see as of 2022, very few studies have actually looked at this particular subject, and I'll delve into that a little bit. But when we look at the studies, a consistent message is that acute coronary syndromes affect relatively young people. The treatment times remain very high, and access to the emergency coronary care therapies is limited. In other words, an interventional cardiologist is sitting there in his restaurant waiting for people to come, but the people aren't coming because access to their particular treatment and to their particular restaurant is significantly limited. Particularly percutaneous coronary intervention is not widely available. And this is important because we know that ischemic heart disease and its prevalence in sub-Saharan Africa is actually on a steep incline. It's rising very, very fast. And we're seeing many, many more people dying and developing coronary artery disease than in the past. So going specifically into this study, 27 studies were reviewed within this systematic review. And the countries in yellow, black, and red are the only countries that have any data on acute coronary syndrome management. And even when we look at that, the red countries have the most data: Nigeria, Kenya, and South Africa. And in each of those three countries, there are 5 published studies that were pertinent to this particular subject. 2 papers from Ethiopia and Burkina Faso, and a single paper from Tanzania, Sudan, and some of the other sub-Saharan Western African countries. So you can see that there's a significant shortage of data. These data, therefore, and the lack of data have drawn many of us to become very interested in this particular subject. You'll probably notice that both myself and Dr. Harun Otieno were involved in this publication, which is really a guidance document to look at how we can improve management of ST elevation MI in low and middle income countries. And what you'll recognize is that not everybody can be treated by primary angioplasty, but thrombolysis in itself is an excellent therapy. When patients get treated early and quickly, then you can prevent significant worsening in the cardiac function. And when there's a delay in treatment, as occurred in this particular patient who came to us from Mogadishu, the time to assessment and intervention was so long that essentially the patient's ejection fraction was not 50 to 55%, but was much worse. And our job is to try and address this. Now, the other major intervention that is effective and one that helps us understand this particular subject is pacemakers. And when we looked at the statistics on the use of cardiac pacemakers in Africa between 2011 to 2016, we found that there was a significant difference across Africa. Specifically, countries like Tunisia and South Africa were short, even though they were outperforming countries like Kenya, Ivory Coast, and Cameroon, but they were still significantly short of the anticipated number of pacemaker implants per population. But what was even more striking was that in 8 out of 31 countries surveyed, 62 million people did not have access to any kind of treatment with a pacemaker implantation. We're talking about countries like Congo, Togo, Chad, Niger, Central African Republic, Guinea-Conakry, Sao Tome and Principe. And you'll see that these are countries that are also relatively isolated within their borders. So a big problem in terms of addressing this cardiac intervention need in Africa. So what is the problem? Why are so many parts of Africa truly or significantly isolated from the interventional cardiology world? Well, is there really a problem? This survey in 2015 demonstrates that there are many countries without even facilities like a cath lab, let alone the interventional persona to support the cath labs. And it's really one of those, is it a chicken or is it an egg? Should we be trying to address the problem by increasing the number of cath labs and wait for the interventionists to arrive? Or should we train more interventionists and get the cath labs operational as a result of that? In fact, actually, the problem south of Kenya is even worse than it is north of Kenya. So what are the limitations in terms of resources and what have we identified from our survey? And the big problem, of course, is interventional cardiologists. There's a shortage. Once you identify an interventional cardiologist, the interventional cardiologists will gravitate and champion their cause. We saw that in Mombasa, for instance, when we arrived at having an electrophysiologist for the first time, and the electrophysiologist campaigned and agitated in order to get an EP lab. And now we have a fully functional state-of-the-art EP lab in Mombasa that is serving the population of Kenya. But take a step back, and how do we make more interventional cardiologists? When I arrived, there were only 8 or 9 of us. Now the numbers are probably doubling. And we had to think about efficient ways to address some of the challenges we face, because when I trained, I did about 3,000 angioplasties before I was allowed as an interventional cardiologist to practice on people in the UK independently. But what we know is that we need to be more efficient and we need to address some of the gaps that we may be facing. So the first thing is to try and maximize hands-on exposure, but hands-on exposure is riddled with significant problems in terms of teaching transactions. And if we look at just the management of an acute MI, we don't have enough patients. Even though they're having their MIs at home, they're not necessarily coming into the hospital. The patient factors like a failure to get diagnosed. Even if you are diagnosed, you'll probably not present to the right person, or the attending clinician may not have the tools to make the diagnosis, and a lack of an ECG is a good example of the important tool that you need to be able to access. And when we did our survey recently, we found that those technologies were not available. If an ECG is done, maybe you're not offered the treatment because you don't have the technology locally. The patient in Mogadishu had an MI. They were found to have an abnormal ECG, but they were unable to make it to a facility locally, and they had to travel considerable distance and considerable time to receive treatment, which was probably too late. Sometimes patients refuse to accept treatment. In fact, yesterday I had a patient, poignant tale, patient who presented with an anterior ST elevation MI, and the whole family decided over a course of maybe 1.5 hours of discussion that the cost and the safety and the concerns around what might happen were an issue. In fact, actually in our hospital, and as in many hospitals, we treat patients and don't ask about money when a patient comes into the acute MI, because essentially the patient has to have their life saved. But historical concerns around this and people making decisions on behalf of the patient meant that the patient allowed us to do an angiogram. We established that there was an occluded vessel, and they didn't allow us to proceed. And that was really, really concerning. But in addition to this, we have teaching factors like maybe a failure to teach. We've got a lot of interventional cardiologists, but maybe very few of them are actual teachers or have the capacity to teach. Or maybe the teachers are concerned that if they allow somebody to get hands-on experience, it may not be very safe. It may be expensive because the student will need more technology to work their way through a difficult space, and it may cost time. And because we're very few, it may be a challenge getting all our students to do the procedures in the time frame that we have allocated. And of course, it may not just be the teacher, but also the patient who's concerned about this. And as a result, in Pascal, we've developed an efficient model which allows us to offer training without necessarily having hands-on exposure. Of course, we are aware of the simulator techniques, so people can practice on a fake simulator, which almost gives a similar experience, and work through modules and learn off colleagues in the same space who've done the procedure in the same day. So 3 or 4 fellows who weren't involved in the procedure can still learn from the procedure. And we found that this has allowed us to train people like Dr. Hashim very, very efficiently with perhaps maybe a slightly lower than normal volume. Another example of resources that are useful apart from textbooks are the ubiquitous availability of YouTube, ebooks, and I'll talk to you a little bit about that, and handling sample products. And this is an ebook that I think will, if you look at the screen, you'll see that in fact it's a moving interventional cardiology textbook, and you'll see that somebody's clicked on the screen there, and as you zoom in and out, you can see exactly how that particular intervention is being performed, and then read around it. It's a really good and modern technology and approach, and this is something that's offered now on both Android as well as, in this particular case, a MacBook interface. But we do this ourselves. You know, this is a patient who came to the acute, who's done as a live in a box case for the Africa STEMI meeting, patient with an inferior MI. We demonstrated how we treated it, how the decision-making was done, almost live. And you don't need a lot of technology. In fact, actually, to record this particular thing, we just had a smartphone and a couple of tripods in order to do this. So in order to improve the efficiency and address the resource limitation that we've been hearing through all our previous speakers, including Dr. Mark Awori, you'll see that the introduction and use of being smart and thinking outside the box is important. Finally, I'll try and accelerate through this and just identify that this is an important subject. We lost Mark To, we lost Emmanuel Maifa, we lost Kamla Dumor, we lost Kajwang, John Michuki, Tom Tolmondley. We've lost a whole bunch of people, senior prominent people, but these are the people who could potentially have access to therapies. We have a whole bunch of people in our own country who are struggling with interventional, with a shortage of access to interventional cardiology. Things are great though. I mean, like if we think about how far we've come and we look at the development of interventional cardiology in our country, specifically coronary intervention, you'll see that in 1975, the first diagnostic angiogram was performed by Dr. David Silverstein, then working from Kenyatta National Hospital. 22 years later, first angioplasty was performed by Dr. Madenge, and angioplasty using stents and then with the drug-eluting stents followed suit very quickly. And then now detailed intervention with thrombus aspiration. Some of the more advanced techniques were introduced later on in Kenya. So now we have many centers, as we've learned, who are now capable of offering this, but they're unfortunately all concentrated in either Nairobi, and some of them all within 1 or 2 kilometers of each other, or 2 centers now in Mombasa, and an upcoming center in Tenwek, and another one hopefully at the MTRH. I've tried to just give you a glimpse and an idea of interventional cardiology, and maybe just to conclude, I'll just emphasize that there remains a shortage of data for African interventional cardiology. The incidence of the diseases that require intervention, however, is on a steep incline, and the resources that we have are significantly deficient, and we need therefore to be efficient with the way that we manage the resources and churn out the next generation of interventional cardiologists. We must encourage training opportunities and address any barriers that exist, and recognize that interventional cardiology remains the final pathway in the management of very acute diseases. There's a big team that's involved, a heart team that, as I've emphasized, is involved in the advanced part of the care of the patient, from when the patient has presented in the first instinct to a primary care physician, all the way to when they are deemed to need and require an intervention. And I'll stop there. Thank you very much, sir.
Yeah, thank you, Dr. Jailan, for that very enlightening talk in an evolving and interesting area. Now, our program was supposed to end at 5. There's one more talk according to the program. We've not had the Q&A session. So maybe I'll defer to the overall organizer, Dr. Juka. What do you think? Fortunately or unfortunately, that last talk is by the chair, that is myself. Should we defer it and go on to the Q&A session, or what do you think? I'll defer to what you think of the overall organizer.
Thanks, Prof. Can you do it in a shorter time? We have 19 minutes, so if you could do it in like
10 minutes.
10 minutes, we can have a few minutes of Q&A.
Okay, I'll try my best. Okay, let me share my, where is it? Here is it. I can see it can move. Okay, so after hearing especially the last three talks, which were sort of high-end things, I'll bring you back down to earth. Hypertension, you heard from both Dr. Jaylan's talk and Professor Polter's talk initially of the significance of hypertension in the causation of heart disease. I have no particular disclosures for this presentation. And this is a figure that is derived from the latest global burden of disease publication in 2019. And I'll just summarize what it shows. On the left here is considering the whole world globally. And basically what it shows us is that the number of people living with hypertension has about doubled in between 1990 and 2019. And that a lot of those people, which is the red at the bottom here, are not diagnosed, they are unaware. And that even those who have been diagnosed, a significant proportion are either not on treatment or on treatment, but not controlled. So when we then focus where we are, which is sub-Saharan Africa, which is the one at the right bottom, it shows basically the same thing, except that the increase in the overall burden of hypertension is bigger, and that the proportion that is undiagnosed, untreated, or controlled is even bigger. So these are two figures that represent some African data. On the left is a meta-analysis of several African studies that was published now about 7 years ago. And essentially what it shows is that if you look at all people with hypertension in Africa, a significant proportion of them are not aware. So only 27% are aware. Not all of them are on treatment. Not all of those on treatment are controlled. So overall, only 7% are controlled. To the right is local data, Kenyan data from our stepwise survey. And the left part of it shows the prevalence of hypertension, an overall prevalence in the adult population of about a quarter, 24%, with the expected increase in prevalence with age. But the bad news is on the right, which again is about the awareness, control, awareness, treatment, and control. So about 15% only aware, only half of those on treatment, and an overall control rate of about less than 5%. So the bulk of our people with hypertension are living there, not knowing that they have high blood pressure, not being treated, and therefore not being controlled. So that is the numbers. How about the consequence? Professor Polter showed this as exact data in a slightly different way. This again is from the global burden of disease. To the left is women, and high blood pressure is clearly the leading cause of death in women. In men, it is second to stroke. If you consider it overally, hypertension is responsible for almost 20% of all deaths globally. That is about 1 in 5, causing 10.8, that is almost 11 million deaths in a year. Now, coming back to Kenya again, we talked about the very poor awareness rates. What are some of the reasons why we have those poor awareness rates? Simply because we are not measuring blood pressure. This is data again from our stepwise survey, the STEP survey. And we have women here, we have men, and we have total. And you can see that if you look at the overall population, more than half of people have never, ever had their blood pressure measured. The men do worse than women. That's about 70%. So 7 out of 10 men living to the age of 60 plus have never had a blood pressure measured. The women, for reasons which are, I think, are pretty obvious, do a little better. But overall, even for women, 4 in 10 women have never had a blood pressure measured. We did another study called the Healthy Heart Africa survey. And one of the things we assessed was to look at primary healthcare workers' knowledge about hypertension in terms of what might cause hypertension, what are the consequences of hypertension. And we did the same for the general public. And the slide is rather busy. You might not see everything clearly, but just a few things to highlight the level of ignorance. So on the left is the health facility worker. For example, less than 30% of them know the association between alcohol and hypertension. About 40%, only 40% know about the association between physical activity and hypertension. Less than half of them know that kidney disease can arise out of hypertension. If you look to the right, which is now the general public, obviously it is worse. So coming next, so the data that I've shown you is at a population level. How about at a clinical level? This is a study we did quite some while ago in the mid-2000s with Loisa Chieng, Prof. Joshi, and Dr. Krari, looking at control of hypertension, adherence, and their relationship. So even in a tertiary center, only 1/4, 26% of our patients had good control. That is the bit in orange there, and it is highlighted to the right of the slide. Good adherence was only present in about 30% of the patients. And as expected, non-adherence was associated with poor control of both systolic and diastolic blood pressures. This is an interesting study that I got recently from a colleague from Cameroon. They looked at an HIV population, and as we would all appreciate, people with HIV interact very closely with the healthcare system. They have to go for their ARVs and all that. In this population, about 25% were hypertensive, but out of those 25%, only 1% were on treatment, and only 1/4 of that 1% were controlled. So clearly there is something that we are missing as the healthcare system in Africa in addressing hypertension. So a few years ago, the World Heart Federation came out with something called Roadmap for the Control of Blood Pressure. And I like this diagram because it illustrates in a very simple diagrammatic way how we can end up with adequate control of blood pressure at the population level, not just at the clinical level. So there is that mass of people out there with blood pressure. So first thing that we need to do is make people know their blood pressure so that they are aware if they are hypertensive. And you remember from the data that I showed you earlier, lack of awareness is really the biggest barrier. Once the people know that they have hypertension, we should link them to treatment so that they start treatment. And we should work towards enhancing adherence so that ultimately they achieve control. So the next few slides quickly will just highlight, before I go there, this slide, I just put it here because clinical hypertension usually is a disease of the middle-aged, elderly adult. This is something that was published in the Lancet a few years ago. There was something called the Lancet Commission on Hypertension. And the import of this slide here is that there's much more that we can do even earlier on in childhood or early adulthood to prevent the onset of hypertension. Nutrition, exercise, Professor Polter talked about pollution and all that. So that our aim should not just be identifying and treating hypertension, but also preventing hypertension. So we as the Pan-African Society of Cardiology, after the roadmap that I talked about, which was the global roadmap, sat down to customize that to the African situation because as I've already alluded to you, our problem with hypertension is particularly serious. And we came up with these 10 recommendations. I won't go through all of them, but there is a variety of things from task shifting to optimizing source allocation to research, to publishing of guidelines, to integration with other the care of other diseases, specifically the infectious diseases, where the infrastructure is much more developed. Since awareness is such a major issue, so there have been programs globally and locally to encourage screening. One of those programs is something called the May Measurement Month, whose godfather is actually Professor Polter. And we in Kenya have participated in the May Measurement Program since its inception in 2017, except for 2020. And highlighted here are some of the publications from the Kenyan activity in May Measurement Month. I also alluded to earlier about a program that I led called the Healthy Heart Africa program, where we screened almost 6 million individuals. And again, highlighted here are some of the publications from that program. Are we making headway? These are results from the 3 published publications from 2017, 2018, and 2019 of the May Measurement Program. And if you compare the control rates that we're getting here, they seem to be better than what we got in the STEP survey. So we're hoping that this represents improvement because of all the prevention activities that have been going on. Obviously, these are not nationally representative data, but we are in the process of repeating the STEP survey, and we'll see if this is proven. The other thing that we highlighted in the program is the question of locally relevant guidelines, and Dr. Murray talked about this. This is the National Cardiovascular Disease Guidelines. This was the launch way back, I think, in 2018. And as Dr. Murray said, we are in the process of revising this currently. So we should be having new guidelines probably in the next several months. Research, as was highlighted by Dr. Amy Okello's presentation in rheumatic heart disease, is important. And one of the issues in treating African patients is that we tend to respond differently to different classes. There's this study that we did, again, Dr. Polter joined us, trying to assess what is the optimal dual combination of antihypertensive treatment in Black patients in Africa. And as you can see, it was published in the New England Journal of Medicine. And this shows which drugs were superior to the other, but I think because of time, I'll skip it. Those of you who have listened to my hypertension talks, you must have heard it like 300 times by now. They usually say that if you are not on the table, you are on the menu. So in 2020, the International Society of Hypertension, at that time, Professor Polter was the president of the International Society of Hypertension. And for the first time when these guidelines were made, because often these guidelines are made as if Africa doesn't exist. And as you can see from this guideline, that if you look at document reviewers for the guideline, there were several of us from Africa. There's this lady from Sudan, a colleague from Mozambique, a colleague from Cameroon, myself from Kenya. And that ensured that the peculiarities of treatment of hypertension in Africa were included. And this slide highlights 2 of the things that I want to highlight. One is the recognition that in many parts of the world, conditions are not ideal to practice medicine as you would have wanted to be, and that you have to recognize that reality. And in this guideline, recommendations were made of what was essential, is the minimum you had to do, even if you are in suboptimal conditions, and optimal if you are in optimal conditions. So we thought that was something that was talking to the reality of our practice setting. The other thing, if your eyes are good enough, if you look at the footnotes down here, this is the first guideline that using the data that we generated in the Creole study, the study that I've just talked about, specifically talked about optimal combination of drugs in Black hypertensives. And this is probably the second last slide. The roadmap for hypertension, I refer to the one that was made in 2015 rather. We had a revision that was published last year. And again, there was representation of Africa so that we're making sure that the realities in our environment are highlighted globally. In conclusion, hypertension is the leading cause of death and disability globally. Hypertension in Africa is characterized by the highest age standardized prevalence rates in the world. The prevalence, like I showed in the first slide, is unfortunately rising. There's poor awareness, treatment, and control rates. There's a unique pathophysiology that we didn't have time to get into, which leads to more complications, which tend to occur early, which require unique pharmacotherapeutic approaches. So to actually control the consequences of hypertension at a population level involves going beyond our comfort zone as clinicians. We have to get out of the clinic and go out there. We have to tackle the various barriers that I've briefly tried to highlight. And in that, we have to use a whole life approach from childhood, in fact, from life in utero, and also a whole society approach, because some of the issues like diet, like pollution and all that goes beyond purely the healthcare sector. Thank you very much for your attention. I don't know how many minutes I used. So, I again now wear my hat as chair. We are at exactly 5. My suggestion to Dr. Ojuka is that we probably give a maximum of 10 minutes of
yes, Prof. 10 minutes should be enough
of discussion, so that we don't have people too late. So I don't know how we do it. There are quite a number of things on the chat box. This is the problem of being the only chair. So maybe what I would do is try to go through some of the comments and direct it to one particular person and hear the comments. So, Neil, this is for you. What are the main reasons that predispose men to have higher numbers of cardiovascular disease compared to women?
Well, it's a good question. The lipid levels, LDL cholesterol, although they're higher in women later on in life, the LDL to HDL ratio is always disadvantageous to men. And blood pressure is higher than men, in men than in women until the age of about 60, 65. So consequently, those two main risk factors are there. And so laying down the atheroma, when that starts as a teenager, your lipids and your blood pressures are better in women than they are in men. Then if you think about smoking, men smoke less than women, and they always have done, and that's all around the world. So you're then into 3 major risk factors, and that's really the explanation. One of the excuses is that women have got estrogen and that protects them. I think the evidence for that is very poor, but I won't take up any more time. That'll do for now.
Maybe what I would want to add to that is that while that is true, it turns out that actually still the leading cause of death for women beyond the young age is still cardiovascular disease.
Oh, absolutely.
So unfortunately, this fact means that we ignore cardiovascular disease in women and don't tackle it enough. It is still the leading cause of death. The next one, I think, is actually a statement about pollution and developed nations. The next one is, what is the mainstay of treatment for obstructive sleep apnea? Mohammed Jailan, do you want to tackle that quickly?
tackle obstructive sleep apnea?
Yes.
I'm happy to do that. Although maybe not sure why I was asked to answer that question. So obstructive sleep apnea, of course, is common.
Because the chairman decided, so you have no choice.
Okay, fine. So of course, obstructive sleep apnea is a disease associated not only with hypertension, but also obesity. And the initial phase of treatment is to try and get the patient to address the obesity. Often when the patient has obstructive sleep apnea, addressing the obesity and getting them to lose weight will result into improvements in their blood pressure as well. Of course, CPAP is an amazing treatment for obstructive sleep apnea and is effective, and they've got now very tolerable options in terms of CPAP that help people sleep with other people in the same bed without it necessarily becoming a significant disturbance. There are some research done into interventional techniques that involve certain parts of the carotid body, but I'm not sure that those techniques have yet been widely adopted and translate into significant benefits. And if you're looking at how best to lose weight, a combination of lifestyle modifications, including dietary, as well as, if necessary, bariatric techniques are useful. I'm not sure if anyone else has anything to add to that.
Yeah, I think that will do for now. I've sort of skipped many of the comments, but I just want to read this comment because I think it's interesting and apt. Just a comment. Looks like in Kenya, if knowledge could come out of Nairobi and university halls, we have all it takes to save ourselves. So some food for thought there. Now, the next one, Makawori, this is yours. My name is George Dulo from UoN-KNH. Are the conditions which require surgical intervention among children preventable? If so, how can they be prevented? Do we tell if a pregnant mother has a high risk of giving birth to a baby with a congenital heart defect?
Okay, thanks for that, for your question. The short answer, to be very honest, is that although we have some theories about what can cause congenital malformations, the diet, genetics, and all this, we really can't prevent it. The trick is to diagnose it early so you can take care of it early. I think I'll leave it at that.
Thank you. I'll probably attend to this one. How long should one monitor blood pressure, start antihypertensive, especially in the office, a level of above 140/90? It basically depends on two things: the level of the blood pressure and the level of whether there is already existing cardiovascular disease or multiple risk factors. So if it's a blood pressure that is between 140 to 159, 90 to 99, with no cardiovascular disease, so-called low-risk patient, you can observe over the next 3 to 6 months. If, however, the systolic is above 160, diastolic 100 and above, then you are encouraged to start treatment more immediately. Immediately does not mean the first day you measure the blood pressure. You want to check it maybe within the next 1 or 2 weeks and then start treatment. This is probably for Fantas, Dr. Mare. Are there deliberate efforts at community level in Kenya getting MI or heart attack prevention and pre-hospital intervention?
Prof, I didn't get you well. I think my network is breaking up.
So it says, are there deliberate efforts at community level getting myocardial infarction prevention and pre-hospital interventions? And Mohammed Jailan can also put in a word if he wants, like, since this is his territory.
That is quite a tricky question for that deliberate action to start coming up with interventions for MI at the community level. It is still, that one is still in the pipeline, but I would want to allude to the fact that we have started partnering with some partners, particularly the farmers, Philips and the rest, to try and start that awareness, but it is still at the very infancy stage. So let me not give a very comprehensive answer as far as that one is concerned. It is still at what we call synthesis, or we are still synthesizing that at the ministerial level. Thank you.
Let me thank you for the
I'm sure you have something to say to this.
Yes, and I agree entirely with Dr. Mare that we're still sort of pilot at a very early phase. But you know, as you're aware, Heart Attack Concern Kenya, Africa, STEMI, PASKI, we've and Stent Save a Life have been looking at this subject very carefully, and actually piloted in 3 counties: Garissa, Embu, and Kiambu, 3 very different counties, to try and improve the systems of care. We got community health volunteers to go and teach and preach at the community level. We created infographics at local vernacular level, and we then gave ECG machines to the level 5 and level 4 hospitals in the region, partnering, as Dr. Mare says, with Philips Foundation. And essentially, the good news is that those 3 counties have now gone, have now in the space of 2 years accelerated their capacity to treat heart attacks and to identify MI patients and to treat them. And actually, today, the first batches of proper thrombolytic therapies have been distributed to those counties, those 3 counties. And the idea is that we'll work eventually through Heart Attack Concern Kenya, Kenya Cardiac Society, and then through the MOH to try and use this as a spotlight to demonstrate that it's achievable and to demonstrate the best sort of approach to managing acute, chest pain in the community, and translating those patients into good, satisfactory outcomes where they can be treated regionally by thrombolytic and then eventually transferred through an improved referral network. It's a very, very big process, and I think we'll be communicating through various groups with the NCT group and Dr. Mare's group in order to try and look at what we've learned from these projects. But at a national level, it's projects like this that are going to allow us to find our own local homegrown solution to this problem.
So this one, either Fantas or Christine Jovi can tackle in relation to pediatric cardiac conditions. What is the government doing to ensure access with experts at the county hospital? Who wants to take up that one?
Maybe I can attempt, and then Prof. Jovi can complete. And what I would say at the ministerial level, what we are trying to do is we are trying to map up human resource at various levels, both at the national and the county level. And after that mapping, although quite some work has been done on this, and the obvious response is that the gap is that big, and therefore that has brought us to the need of us strengthening the capacity of existing health workforce to handle very specialized cases for cardiac conditions, especially pediatric conditions. And therefore, the ministry has to work very closely with the academic institution, particularly the university, so that we can increase the level of human resource to handle this very, very specialized area. So what we are doing at the ministry is that we are trying as much as possible to get those medical officers and cardiologists who are interested in this, so that they can get the necessary support to learn that. And also, we are also collaborating with the university so that they can provide the necessary course as far as pediatric cardiology is concerned. But I'm sure Joey can really make a very positive comment on this, better than mine. Thank you, Prof. Joey.
Christine, any additional comments?
Yeah, we've been working closely with the Kenya Pediatric Association, and we were targeting the county pediatricians in terms of early referral and awareness. It is coming up. I think we just have to press on, and we're also having a number of pediatricians pretty interested. So we probably will have some more short courses on this, just to see if we can improve the knowledge gap. Thank you.
I think that's quite an important point. I mean, it is going to be a long time before we have enough pediatric cardiologists. So it's sharing to the pediatricians, and the pediatricians training the medical officers, etc. The 10 minutes I asked for are over, so I'll pose the last question, which either Mark Awori or Christine Joey can tackle. It was actually addressed to Dr. Awori. What is the relationship between the use of NSAIDs in pregnancy and congenital heart disease? Any takers?
NSAIDs in very low doses, like the junior aspirin, is commonly used by obstetricians. When you go to those higher doses of more than 50 to 60, 70 milligrams per kilogram body weight, then you risk shutting the PDA in utero, and you risk some dysfunction. Especially what I have seen is when they are used in the last trimester, we do have some disasters occasionally. But that is aspirin. Yeah, that's aspirin. I don't know about the others like Feldin and the rest of it, but I know more of aspirin.
Mark, is there anything you want to add to that? Mark is silent. I think I'm usually very particular about time, and I recognize that maybe many people would have organized for other things past 5 o'clock. So let me just take this opportunity, one, to thank very much the speakers, who all happen to be my colleagues and friends, for answering to my call and for giving really fantastic presentations. And to the audience, at peak, we reached about 900. I see we are at still about 480. So clearly there was a lot of interest. To the Secretariat, Dr. Ojuka, the Dean of the School, the Faculty of Medicine, for organizing this and asking me to moderate it. So thank you all very much. Have a wonderful evening. So I hand over to Dr. Ojuka. Thank you very much.
Thank you, Prof, for a very good job done in terms of moderation and the questions. I want to appreciate each and every one of you who came, the speakers, the panelists, and the time they've given us, over 3 hours on this. We are at 16 past 5 from 2. We really do appreciate. And we thank you for those who endured the long time. We've gone past time, but we appreciate you giving us the 16 extra minutes of your time this evening. We thank you. We continue tomorrow. Tomorrow we will be looking at the whole issue of epilepsy and cap it together with just looking at the anthropological impacts of NCDs in Kenya. So you are welcome tomorrow too. beginning from 2. I thank you. Have a good evening.
Thank you.
Thank you and bye, everybody.
Thank you, and bye too.